This afternoon's session will focus on caring for people with MND. And I'd like to introduce our host for the session, Professor Amar Al-Chalabi. Professor Al-Chalabi is an award-winning consultant neurologist and director of the King's Motor Neuron Disease Care and Research Centre at King's College London. He also co-leads the international Project MIND consortium, which is undertaking whole genome sequencing of more than 22,000 people, two-thirds with ALS. Professor, thank you.
So, hello everyone. I'll be your host for this afternoon's session on caring for people with motor neuron disease. We're going to follow the same format as this morning's session, with all the speakers presenting their individual topics and then a group question and answer session at the end. First up is Professor Chris McDermott, who's Professor of Translational Neurology at CITRAN, which is the Sheffield Institute for Translational Neuroscience, and he's a consultant neurologist at the Sheffield Teaching Hospitals NHS Foundation Trust. He's here to talk to us today about developing the evidence base for symptomatic care.
Thank you, Amar. I'd like to thank the organisers for inviting me to New Zealand for the first time ever. So, some disclosures. I'm going to talk about, very briefly, just an overview of symptomatic care. And then, because I was looking at the other talks that are on the agenda this afternoon, there's talks about NIV, there's talks about palliative care. I thought I would focus on nutrition, as that did seem to be covered. But generally, this is how I think about the treatment for motor neuron disease. We have neuroprotective therapy, so we have riluzole, and we've heard about that. Then there are lots of symptoms that people with motor neuron disease have to face on a day-to-day basis, and there's quite a lot we can do to manage those symptoms. And then underpinning all of this is a multidisciplinary approach to supportive care. So we just look at those. We've seen this graph already. This is riluzole, which over the course of the study led to approximately a 3-month benefit. And so we encourage our patients to take that, because those who live longer will have more benefit than that. The biggest intervention we have, though, is non-invasive ventilation. So you can see the survival curves are quite wide here. So in the study done in Newcastle in 2006, the survival advantage was about 7 months. And I think most people would agree that we're seeing more than that in day-to-day practice now. And the important thing here is that it's good quality life. It makes a big difference to people's quality of life, non-invasive ventilation, and that's us using it at night to treat the effects of sleep disordered breathing. So this is our data. We were late to the scene here. Many others had published this. Our little twist on it was, so this is the general neurology clinic and then the multidisciplinary care in orange, and there was a survival advantage. And when we looked at it, it was independent of riluzole. It was independent of whether you put a feeding tube in. It was independent of whether you're using NIV or not. So there seemed to be an effect of actually attending the clinic over and above these interventions. So that's interesting. What that is uncertain. Could it be better secretion management? Some people have suggested it might be something such as the provision of hope and that sort of feeling that people get coming to the clinic. But I don't think we know what that sort of X factor is. So, symptomatic treatment. There are many things that patients with motor neuron disease have to face on a day-to-day basis. I'm going to focus on nutrition, but I think the important thing to say, one of the things that sort of drove me down this particular sort of research program, is I used to feel very uncomfortable sitting in my clinic when a patient would be talking about a troublesome symptom such as secretion. And I think, well, what am I going to do with this? What's the next step? And you consult the literature, and there is really no evidence in the literature. It's just the experts saying what they do. And I felt uncomfortable with that. So we've set about within, certainly within the UK, we have I'll show you, we have a wide network of trying to work through these different symptoms and trying to begin to sketch out a proper evidence base. So we don't have this sort of black hole where you would want the evidence to be to guide treatment. So I'm going to focus, though, on nutrition. And this question, could getting it right make a difference? Is nutrition important? So I think there's increasing evidence that nutrition is important. We know that weight is a risk factor for motor neuron disease. We know that weight loss is a poor prognostic factor in ALS. We know that mild obesity, with a BMI of in between 30 and 35, seems to be protective. Hypermetabolism is a concept that's been evolving over the last decade. So we know that someone with motor neuron disease, they burn up more calories when they're sitting doing nothing. Their resting energy expenditure is on average about 20%. Not in everyone, but in a good proportion of people with motor neuron disease. And that hypermetabolism, burning up more energy, stays constant throughout the disease course. What causes this hypermetabolism, we don't know. There have been lots of theories. Could it be that people are having to use more effort to breathe more? Is it because of all the fasciculations and things that are going on? And that's sort of been excluded. So we don't know. We know that the mitochondria are abnormal in motor neuron disease and that they're perhaps not as efficient, and that's a potential plausible hypothesis. But it's not proven. We don't really understand this yet. We've heard about mouse models of motor neuron disease. So this is the SOD1 mouse. And you see some changes in energy metabolism here. Early on, the mouse begins to use fatty oxidation rather than glucose as a pathway for generating its fuel and energy. You see a similar hypermetabolism in the mouse that I've just described in the human. And if you correct that energy deficit in the mouse by giving it more food, so trying to meet the need that it has, you extend the life of the mouse. So that's interesting. But that's a mouse. What about in humans? So this was a small study, which I think it is interesting, but it's not the definitive answer to this, but this made me particularly interested in exploring this further. So this is people who have gastrostomy tubes in. So this is much later on in motor neuron disease, not at the start. And what they did in this study, they gave people more feed through the gastrostomy. So that's relatively easy to do. They increased the feed by 25%, either a high carbohydrate or a high fat increase in feed. And the blue and the red lines, survival was much better than in the control population in the green. So this was interesting, but I think it needs to be done in larger numbers. It's not been replicated as far as aware. And what would be particularly interesting if this is having some sort of effect, what about if you brought it much earlier into the disease pathway when people were diagnosed? So let's go and have a think about what's happening at diagnosis. So our hypothesis that we're currently exploring as a consortium in the UK, and so Martin and Amar are involved, and David is going to speak later as the chair of our steering committee on this. Our hypothesis is an early high-calorie diet will prolong function and survival in ALS. Anyone who wants to lose weight, just telling someone to eat less, it doesn't work. There's all sorts of diets, this and the other. Just telling people to do something to make a change in the behavior doesn't work. And similarly, I think telling somebody with motor neuron disease just to eat more, I don't think that's going to work either. So what we're interested in doing is understanding, first of all, before we go forward with our intervention, attitudes, enablers, barriers, to optimal nutritional management for patients when they've just received a diagnosis of motor neuron disease. And then we're developing sort of in a co-design methodology an intervention to support a high-calorie diet in ALS, not just telling people eat more. And then we're going to evaluate it in a traditional manner in a randomized controlled trial. So current nutritional management, this is where we started. To bring in a new intervention, we thought, and it's a complex intervention, we thought we need to understand what sort of framework this is going to go into. So we undertook various reviews. So we did a mapping review. We got lots of guidelines and documents, but most of these were just high-level overviews. There was very little evidence on how to give nutritional support to patients with motor neuron disease. There was a lot of evidence around SLT involvement, but not much evidence of dietetics involvement in the literature. This is just an example. So these are the large European guidelines and the American guidelines. There were systematic reviews, consensus opinion, and there was a focus on dysphagia, ameliorating dysphagia, and when you put in a gastrostomy tube. What there wasn't was anything on, at diagnosis, how we should be assessing patients' nutritional status, what's the recommended dietary intake, what should you do about oral supplements. And then for the gastrostomy population, there wasn't really anything on the method of feed administration or indeed what should be in the feed, and I'll come back to that in the second half of the talk. So then, having done that sort of quick mapping review, we then wanted to explore in detail well, what's actually happening on the ground. So we've taken a multi-layered approach to this. We started off with some focus groups, and then we did a national survey of healthcare professionals, and then we also did a freedom of information request, which is by law, organizations have to respond to a freedom of information request, so it's a good way of finding out how services are set up and how they're funded in the UK. So from the focus groups and the surveys, we had a broad range of healthcare professionals responding. The freedom of information request, we had a broad range of commissioners and then healthcare providers throughout the UK, as well as some hospice organizations, other non-NHS. And so I'm just going to pull out a few things from this. So the first of all was about the timing of nutritional care. So only 31% of the brackets tell you where the information is extracted from. So the S is the survey, FG, focus groups, etc. So 31% of patients with ALS were referred to a dietitian at diagnosis. So that's very low. ALS dietetics referrals were often declined because dietetics services had these arbitrary cutoffs that they can't see you until you've lost 10% of your weight. And that was astounding. And then even if the referrals were accepted, there were often very long waiting times. And from the focus groups, as dietitians, we end up getting involved at a crisis point. So that's what's going on in the UK. So who's providing this care? So 77% of non-dietitians are providing nutritional advice. So that will be the specialists, nurses, speech-language therapists. And a good proportion of these did not know or use any particular guidelines. And then, as I've already shown you, those that are using guidelines, the guidelines don't have anything in to tell them what to do anyway. And so people are saying, I'm not looking for anything that is prescriptive, but it would be nice to have a bit more guidance, a bit more evidence behind things. Organization. So 80% of organizations have a dietitian, but very few are specifically dedicated to ALS. They're often working across many different diseases. They are, however, working in MDT, which is encouraging. But it's having access to the dietitian that you get a sense that they're not actually truly embedded within the MDT, the sort of email contact, and there's an issue between communication. We then, in the survey, looked at, well, what advice are those that are seeing a dietitian, what are the dietitians saying to them? And this was asking them about the weight goal. And if we're thinking that really we want to be, if the hypothesis is having a higher calorie intake is going to be better, for all of these weight groups, you could argue that there should be weight gain as a target. But it's quite shocking, really, that weight maintenance is being advised in a large proportion here, and weight loss is being recommended for anybody with motor neuron disease, if this hypothesis is correct, which is yet to be proven. So when you see all this variation, that's often a sign that there's no evidence to guide things, which is unsettling, and I say the weight loss is an issue. So then, how are they setting the weight targets and the calories that people should be taking to reach those weight targets? So they're often using the Henry equation, which isn't validated for ALS. It's from a healthy population. We've talked about hypermetabolism, there being 20% higher measured resting energy expenditure for people with motor neuron disease. So is there any extra being recommended? Well, 75% of dietitians do add a stress factor in, but it's a bit lower than the hypermetabolism we've seen. But 25% don't have a stress factor added in. So in the focus groups, we also looked at barriers and enablers in terms of introducing better nutritional care. And these are the sort of things that come out. And it's not surprising, really. You know, what will be a barrier to telling somebody to eat more at diagnosis? So those early steps, it's about denial, perhaps, that they have a motor neuron disease, a problem with engagement and compliance, and they're going through a period of psychological adjustment. This is then followed by a period of a need for control, and suddenly telling somebody, well, you've got to do this, you can't eat that way. They sort of lose control. But it could be reframed that actually empowering them to be able to do something might give them back some control, so it could also be a positive thing. Knowledge and complexity of motor neuron disease, so the clinical language used can be a barrier. The disease progression, we'll come on to that. There are lots of healthy messages around eating that we have all our life, and a lot of the messaging around eating more is against all that. And then eating is a psychosocial thing, so we've all just had lunch, we've all just been chatting, and so it's whatever we do needs to factor in this as well. Sorry, the Mac PC compatibility is struck here, making them all a bit funny. So in developing the intervention, it's a complex intervention, it's a behavioral intervention. So I'm not a psychologist, but we have psychologists on board our team, so a professor of psychology at my institution who's helping us with this. So again, it's not just about telling people to eat more, it's about creating a framework around the COM-B model, so people need to have the capability, the opportunity, and the motivation. And I'll go into those issues a little bit more. So we've done a systematic review looking at what factors are associated with oral nutritional behaviours in ALS, and we've split them into the COM-B model. And the purpose of this is so when we get into the design phase, we're making sure that we're taking these features into account. So somebody obviously has to have the capability, the physical capability, and that needs to be taken into account. There needs to be psychological capability, and that's, we now understand much more, thanks to the work of Orla and others, about the cognitive impairment. But we also have to give them the knowledge about what a high-calorie diet, how it could benefit them, and how they would do it. We need to think about the opportunity, things such as the absence of caregivers. We need to motivate patients so that, get over the fact that there's a low perceived need to do this, or there's an idea that they won't respond to a high-calorie diet. And then we need to think about eating habits, depression, and loss of appetite, these sort of automatic motivation things that are just going on in the background. So whatever we develop needs to target these factors. We also looked at what other sort of nutritional interventions are out there. In green there are various things that we came across in the literature, and we wanted to extract from them what were they doing in terms of behavior change and modes of delivery to achieve a high-calorie diet. And we went much broader than just motor neuron disease. We've looked at other just neurodegenerative disorders. And the behavior change techniques in yellow there, so making sure people have a good instruction about how to do this. self-monitoring, so many of you will be wearing Fitbit devices or the richer ones, Apple Watches, and you'll be, looking how many steps you've done. So that's self-monitoring, reinforcing behavior, practicing the behavior. And in terms of mode of delivery, human and face-to-face. So if we're going to develop, say, an app, I think an app on its own isn't going to be effective. So it's a sort of blended thing, we think. So this is our user-centered design process. It involves patients, designers, healthcare professionals going around the user co-design process. And we've been going around this over the last year, having done that, the background and the scoping that I've already described. We're now in this iterative phase, which we've been doing for about a year now. And we're just now people are now living with the intervention. So the intervention is called OptiCals, optimal calories in ALS. And it's a portal, and it's designed for both healthcare professionals and for patients. So there are various parts of it, and what we've tried to do is, so this is Sean, who's an amazing dietitian on our team, and what we've tried to do is put Sean's knowledge into our clinic, our nurse, our MND nurse, but also into the patients, and so they don't need to wait to see him, they don't need to refer to see him. So we think the absence of dietitians is a real problem. If we're going to bring that knowledge about a high-calorie diet, we need to be doing it much earlier. So there's 50-odd videos, little short segments with all the sort of tips and tricks about how to get a high-calorie diet. It can be tailored. The healthcare professional, the clinical nurse will tailor the videos and things that match that particular patient's need. And there's lots of infographics explaining the why, giving people the knowledge. And there's a sort of food diary where people can record what they're taking in a very easy manner, and they get self-monitoring and reinforcement of how they're doing. So the patient portal, it's giving them knowledge about nutrition, it's self-monitoring, they have personalized goals, which are based on the Casarsis equations, which are validated for ALS. And there's lots of resources to help them get their goal. And then for the healthcare professional, it's giving them knowledge about nutrition, they're monitoring the patient, they set the calorie target for the patient, and they have support through our online dietitians and their own peers. So that's how it looks. So there's people living with it now for a month, so they're seeing how they use it, and it's going out in centres around the country, and then we hope to start the formal trial in quarter 3, 2020. So that's at the early phase. What about later on gastrostomy? So this is another evidence-free area when to use gastrostomy, or if to use gastrostomy. There have been no robust trials, but it's commonly performed surgery, and the majority of patients with motor neuron disease end up with a gastrostomy. What evidence is out there? So there's never been an RCT. If someone came along now with the idea of, why don't we put gastrostomy tubes in people, it wouldn't be done without an RCT, but it's just something that developed with CREEP over the years and now is accepted as standard practice. There have been some observational studies. Some say yes, there's some survival benefit. Some say no. And then there's lots of retrospective cohorts, so over 3,000 patients. 6 say harm or no benefit, and 2 said benefit. So it's a real mixed picture, quite unsatisfactory. So we haven't done an RCT, but what we did do as a UK network, we looked at gastrostomy in patients, ProGas, a prospective observational cohort, and we wanted to ask, were the different outcomes for the different types of tubes, and I'll come on to that. What was the best time to put it in, and could we say anything about nutritional outcome? So this is our UK network, and this would be something, if you want to move forward in doing clinical research, I think setting up a registry and setting up a network. So everyone here gets together once a month by a teleconference, and we manage the trials that are going on, and we have ideas and talk about, which problems or drugs we want to test next. It's a very effective collaboration. So in this study, we recruited 345 patients, 233 carers. If we just drop back down here, we got data on 323 patients who are having gastrostomy feeding. We asked the clinicians, and if we just focus on this one, why are you putting a gastrostomy and what's the benefit to your patient? And it's about stabilizing nutrition and hydration for most was the top thing. So then this was the surprise, the main result. Weight loss. So nearly 50% continued to lose weight. Many didn't change, and most of them had already lost a significant amount of weight and remained malnourished, and a quarter gained some weight. So this was a surprise. And then if you looked at, so this is complex, but if you just look at this here is patients who actually if I go back, it's not come up very well. So these are patients who had lost more than 10% of their weight at the time that they went in. And then at 3 months, the majority of them had still lost more than 10% of the weight. So what this slide is showing is that those that had lost most weight, had lost 10%, they didn't put anything on. So the ones that you think who would definitely gain and benefit from the procedure, those were the ones that didn't, and this group also had higher mortality. So those who had lost most weight, more than 10%, didn't put the weight on, and also were at more risk of mortality from the procedure. Now, what's causation and what's association is difficult to tell because it is a prospective observational cohort, but it was a troubling observation. What were the reasons for the nutritional outcome? Well, weight loss due to continued denervation, possibly, the hypermetabolism, the poor post-gastrostomy feed management. So as a neurologist, we put the gastrostomy tubes in, and then the feed is managed, if I'm honest, I don't know how it's managed, or I didn't when we did this study. It's managed in the community, often by sort of nutritional firms who are providing the feed. It's not sort of prescribed. We're not involved as the centre, and is that part of the problem? And then there's a concept in cancer that you get a change in the way the metabolism works. You get this refractory cachexia when you've got more than 5% weight loss. There's something like that going on. The other thing we looked at was the type of tubes. There are broadly two types of tubes. There are big, thick tubes, which are put in through an endoscopy, and they're fixed internally with a big sort of rubber flange on the inside, so they don't fall out. Or there is easier to put in rig tubes, which are just done under X-ray guidance at the level of the stomach, and the small tubes, and they're either stitched in, or once they're in, water is injected to a balloon that holds it in place. And what we found was that there was much more complication in the green. You can see the balloon retention tubes. So the conclusions for us, that the expert opinion was perhaps incorrect. The majority have no nutritional benefit. We don't know why. Delayed feeding may lead to diminishing benefits and greater risk. So mortality was higher if you'd lost more weight, and those with greater than 10% weight loss failed to regain any weight. The methods were equivalent in terms of safety, although there were more complications with the small stitched-in tubes. So our recommendations were optimal feeding tube practice should be to use the whiteboard tube with an internal stopper. Don't use the small stitched-in tubes, and insert a 5% of weight loss if you're going to do it. Don't wait until patients have lost 10% of weight. I think just get on and do it if we're going to do a gastrostomy. And that's been adopted now by NICE. So there are unanswered questions. What is the ideal nutritional prescription after a feeding tube has been put in? And we're answering that now with another sort of similar approach to last time, but the detail focuses on the post-gastrostomy management in terms of feed management, what's going on. So we're looking at that now. But we don't know this yet, I don't think, and that remains troubling for me. There are factors that delay gastrostomy. We did some qualitative work. It was not uncommon for there to be delays from a patient perspective. Understandable things, reluctance to give up oral feeding, uncertainty over disease trajectory, not realizing potential benefits, and lots of negative perceptions of gastrostomy. So once we'd finished doing this study, the traditional thing is just to deposit it in a library, in a journal. They used to look like that, they now look like this. But what didn't seem right is that really going to influence things? And we wanted to have our patients understand this piece of work. We thought it was important for that to happen. So this sort of user-centered dissemination where we take our research findings, work collaboratively with people affected by motor neuron disease, and get them to integrate our research findings with their lived experience so they can create a resource that would help others, something that would have helped them if it had been in existence. And so this is MyTube, which we did. So here are patients, and we've explained the research findings to them, and then we get out of the way. And we put them in a room with web designers, filmmakers, and they tell their stories and integrate it with the literature. And they developed MyTube, which is the web link is at the bottom here. So if you just Google MyTube MND, it's usually quite high up in the Google searches. And what's important is it's lots of videos about the patients talking about what they did. So it's them talking about them thinking about the tube. It's them talking about what it was like having it fitted. It's what it's like at home. And there's like videos about people having the feeds delivered and thinking about when it all arrived. I didn't know where I was going to store all this stuff. No one had told me. You know, my whole understairs cupboards would be full of feeds, you know, things which if I'm honest, I didn't know what were going on either. So it was quite insightful for me. And then what it's like caring for someone with a tube. And it can go into quite a lot of details. This is the thinking section, thinking about a tube. And it's not all positive. It's people, saying no, why it said no, and talking through those things and what they did instead. So I think it's quite balanced. And things about little tips, the different ways you can use the feeds and things and why they like one more than the other. So it's quite a rich resource. So that's it. My acknowledgements. So Pam, who I work with, who mentored me and supports me. There are lots of teams involved here. Our own Sheffield MND care team. Harris, Theo Harris, leads on post-gas, ProGas. The patients who developed MyTube, the HiCals team, some of whom in the room, and the UK Motor Neuron Disease Clinical Studies Group, some of whom are also in the room. So a lot of teamwork. Thanks.
Next on the agenda is Sarah Solomon, here to talk to us about occupational therapy for people with motor neuron disease, adjusting and adapting to rapidly changing function. Sarah is the Senior Occupational Therapist at the statewide Progressive Neurological Diseases Service at Calvary Healthcare Bethlehem in Melbourne, Australia. When her mum was diagnosed with motor neuron disease in 2012, Sarah was a primary carer for her until she passed away. Sarah is passionate about ensuring people with motor neuron disease can live their best life with the changes occurring.
Thanks, everybody. I'm Sarah. I apologise if I walk away from the microphone. I'm a bit of a talker with my hands. I have no disclaimers. I'm an OT who works in public health, who gets paid public health and has no money for research. So on that disclaimer, I'd like to say all of this is about just my experience. To add to the mum thing, I'd actually been working at the MND clinic for 6 years before mum was diagnosed. So all of the things that I'd like to share are professional and personal. I've only actually started talking about mum, and I'm not going to talk about our journey because it's our journey and it's not anyone else's journey. But some of the things that I'm going to talk about are things that we found useful, and the rest are from about the 1,000 other people that I've helped over the course of my career. So I always say to my clinicians when I'm employing new people that I will employ on organisational fit. I can teach skill, I can teach wheelchairs, eye gaze, but I can't teach this. And I think it takes a certain person to work with people with MND. I say to my juniors or my students, if you want to work where there's a clinical pathway to follow, go work in an orthopaedic ward. Don't work here. So anyway, as we like to say, it's currently incurable, but we've heard lots of things today about hopefully that's going to change and then I can retire and I'd be happy. But it's treatable. And I'm so glad that all of the neurologists that have talked about the importance of a multidisciplinary team. I'm pretty lucky to work with Paul Talman, who's not here today, and Susan Mathers from Calorie, who've been building the clinic that I work at for 30 years, like incredible. And you'll see all through my slides about working with a team. OTs don't work in silos. We work with the physios, the dietitians, the speechies. Everything's got to be together. But the reason I started doing these talks is because I would get lots of phone calls from therapists out in the community saying, oh, I've just been referred someone with MND. I don't know what to do. It's scary and I don't know how to talk about it. And so I started kind of doing these educations, and then it got bigger and then it got bigger, and I'm running a webinar next Wednesday in Australia. It's just gone a bit crazy. So that's Mum. That baby is now 13. She also lived in the country. So you talk about the challenges of New Zealand and the regional and rural areas. She lived 4 hours from the nearest big town. So we're talking all of that difficulty, distance, access to therapists, access to neurologists, access to respiratory, all of those things. But you know, the funny thing is, because I lived in the bush growing up, I went to boarding school and then I went to uni, and you know, my parents paid for all this stuff. And before Mum died, she typed out, you know, Sarah, my investment paid off. I was like, yeah, thanks, Mum. Anyway, I think the thing that I'm going to talk today, this is about OT, because I'm an OT and that's what I know, but for the physios or the speechies or anyone else, the kind of principles are the same. It's like understand the phenotype to start with. MND is an umbrella term, as we've heard, for lots of different subtypes, onset location, and people with MND don't know what they don't know. They don't know where things come from. So there's so many times I will say to people, I just want to show you this thing that someone else has found useful. It may not be useful for you because you know you and your people know you, but this has helped someone else. So maybe it'll work for you. And I work on a principle that I'd rather people go away armed with knowledge. Sometimes you have to dance with that knowledge. Some people come into clinic, they want to know everything. Other people come into clinic, they don't want to know very much, and that's okay, and we just dance the dance, depending on where they want to be. But the one thing I do say is that I'm always going to be here. You call me, you email me, we can't work in a time where you only get reviewed every 3 months in clinic, because we know things change, so let's just go with the flow, and you call me, email me. And so the thing I talk about is like understanding the phenotypes to just help guide the process. So my tips for OTs, understand the phenotype. If someone has bulbar onset MND, I don't talk about bathroom modifications straight away. I talk about access to speech generating devices with the speech pathologist, or a bed wedge to help with secretion management in bed so they can sleep better. Or if they've got respiratory changes, let's look at different things. Be proactive. I think you're kind of proactive in your head, not always out in the discussions. The smart and strategic use of funding, and I know that Claire and I have had discussions about the funding challenges in New Zealand. For those of you who are aware, Australia's just gone through the biggest funding reform since Medicare for people under 65, which is creating a whole lot of funding challenges for us. But, you know, people with MND have never fitted into the model of funding for care or services in any state, government, country. They've never done it. So we've just had to make it work. And I think this is one of the things I say to therapists, just make it work. Just do what you got to do. I may have bent the rules quite a few times, that I'm too old these days to really worry too much, as long as the person gets what they need when they need it. And that close to perfect solutions might be good enough. And I say that in a kind of weird way. In Victoria, we have a sort of pool of equipment we can access in the short term for people with MND, and power wheelchairs are one of those examples. There's, you know, 6 different types of power wheelchairs, and And sometimes we just have to pad them in a bit with some cuddle buddy cushions, because by the time that we got something totally revamped, the person would have changed, so then it's out of date again. And I don't want to spend the person's time going back into clinic every week to fix this. So we're very creative with our solutions, and I'll show you a couple of things that we've done. And be creative and not prescriptive. Put recommendations in writing. Now, Paul Tarman's not here today, and he was going to talk about the development of our clinic, and one of the things we do is we've developed a thing called a shared care plan. It's nothing to do with funding. It is just a sharing of information. So people come to clinic, they would have had a triage call, would have, the clinic nurse would have asked, is there things that you want to talk about particularly, work out what clinic appointments need to be happened, and then it is written down who they saw, all of the things they brought up, anything that we brought up, what the sort of discussions were, and who's going to do what. Because we're talking a language that is new, unfamiliar. People can't remember everything. I can't remember everything when I go to the GP, let alone like 6 clinic appointments. And that's something that our neurologists are very, very keen on, is this model of shared care planning. It also gets sent to any of the other clinicians that are available out in the community, so that everyone's working on the same clinical reasoning and the poor person doesn't have to regenerate their story every time. And that people with MND require regular long-term input, which I think we all know. So challenges for us in general, they require flexible, responsive input. Sometimes there's limited time to adjust to something before something else changes, and that there is a vast array of changes that can happen, and we need to understand that to then use that knowledge to help the person with whatever they need. And the psychological adjustment to the neuropalliative diagnosis is something that we really need to kind of be mindful of. And I often will spend time in clinic just reading maybe where my person is at, because that helps me work out how to talk about things. I'm just going to talk about a few kind of random things that I've done over my career. So everyone remembers the light writer. And, lots of people have moved on from the light writer. But, there is still the new light writer, the new Allura. But obviously you need to have fairly good finger touch. And I had a couple of the speechies come to me and say, oh, Sarah, so-and-so loves her light writer. She's using a pen. It keeps slipping off. So I made these splints and I got some rubber thimbles and I stuck them on the end. Worked a treat. Upper limb management. I think this is something when OTs talk about upper limb management, they think about splinting or, like stretching or ranging, but I like to think of it a little bit as well as sort of the whole upper body support. And this is where I got laughed at the other conference that I presented at last week, because this blue pillow over here, we used to sew these. We had a sewing machine in our OT department, old school. We since redeveloped, we don't have a sewing machine anymore. So we're like, where are we commercially available? We're going to try and find a commercially available version, because people find these super comfortable if they're in the car and they just want to be able to rest their arms. They're not, no shoulders being pulled on their recliner chair. IKEA breastfeeding pillow. Oh my God, my husband thought I was nuts. I came home the other day with like 10 in the car. He's like, do you have something to tell me, babe? I'm like, no, it's okay. But $40, breastfeeding pillow. Cuddle buddy cushions as well, we use a lot just for sort of transient use. They can get shoved in places, behind necks, under arms. Don't tend to make as many thermoplastic splints as I used to. I think things have moved on. We manage sort of upper limb changes better. But yeah, supporting for respiratory, sitting in a recliner chair, not sitting like this, sitting like this. It's all about quality of life. I know that we've got other talks on electronic assistive technology. I suppose my one disclaimer is that I work as an electronic assistive technology consultant for a company called Zytec in Melbourne, who import and provide some of the eye gaze technology, one of the companies. So it is something that I do quite a lot. I'm not going to talk a lot about it, but more just the philosophy of you approach electronic assistive technology like you would approach anything else. You don't give person A, decide that this is the wheelchair they need, and then person B gets exactly the same wheelchair, because they've got different needs. They want to drive it in a different spot. They've got a different house. So it's about what do they want to do? What are their goals for using it? So for someone with cervical onset MND, one of the things that they might say to me in the early days is, Sarah, it's really like annoying, I can't use my mouse. You know, I can type, but I can't use my mouse. So we don't go straight to a whole new system. We kind of adapt it as we go along. But then the access is, as an OT, one of the most important things. Like if they can't drive it, they can't do anything. Being a country girl, I do the old learn to drive in a paddock, in an old car with someone next to me. It didn't matter if I crashed into anything. It was really slow, made lots of mistakes. Same deal. When someone is learning to drive technology in a different way, it takes time, and that's okay. And then what combination of hardware and software, and what do they want to do? Do they want to turn the TV on and off? Do they want to turn the lights on and off? Do they want to go on Facebook? Do they want to tweet something? You choose the software related to that. And then where they want to use it. So that comes back to the mounting, positioning, portability, battery life, all that stuff. And then trial and practice. We're pretty lucky where I work over the last 10 years since the first eye gaze we did, which I literally wheeled in on a giant table, and the butterflies in China had to be flapping their wings in the right time for it to actually work, is we've now got a technology room, because our funding in Australia is so slow that we couldn't even get trials of things. So over the last 10 years, I've applied for lots of grants, and we now have a technology room set up where if someone happens to come in and they make the mention that they want to look at some things, I've at least got things to show them, and they can try things and at least have a bit of a touch and a feel and work out if it's something they want to kind of go along the lines with. I think it's really, really beneficial because, again, people don't have time to wait sometimes, so we just have to do it. You also can't schedule that stuff. It might just come up in conversation, so we just go from there. So this is some of my people. Other disclaimer, full permission to use everybody's photos. You can see all the different things. The top lady up here, I got an email from her husband a while after setting her up going, yeah, thanks, Sarah, my credit card's just about to explode because she's back on eBay. Yeah. All of the people, all of my people. You can see all the permutations. This lady on the left here, so she communicates using a head mouse that's mounted on her tablet. She's also got a scanner on her wheelchair, which actually has an environmental control unit built into it, which she controls with her knee. So she communicates with her head and drives a chair with her knee. This lady on the right, a lot of her things were around, she couldn't communicate what she wanted to eat. It was this big battle with her and her husband. What am I going to eat? So I programmed a whole lot of grids with just all the different things that she wanted to eat. But at the end, I put in one of the grids so she could just click it. And it said, Bob, 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 because that's apparently what she used to say to her husband. He was like, yep, thanks, Sarah. Well done. Assistive technology, equipment. There is a huge amount of stuff available now. It's about providing options. I don't profess to ever prescribe anything. I will give options, talk about the pros and cons, work out what's right for that person. It can be a symbol of loss, so it's a really sensitive area sometimes. And we use the knowledge of onset patterns, which I've said before, to work out what we might need to talk about in a particular appointment. And that some equipment may be only useful for a short time, and that's really okay. Beds. Now, I can do a whole talk on beds, but I think the one thing they'll take away from you is I don't call them hospital beds. Electric beds, profiling beds, beds that move, anything but a hospital bed. To me, when someone talked about a hospital bed, even as an OT, it was horrid. I didn't like it, and I actually changed my own practice after going through the experience with my mum. So electric beds, beds that move, amazing. But talk about companion beds, sexuality, intimacy. I don't care what it is, but acknowledge it, and it's real, and it's normal, and that's okay. And we are lucky enough to have a bed that we can loan to people if someone needs a companion bed, and talk about the fact that you can get the beds at the same height for during the night and then move them up and down when needed. Or like one of my guys who just didn't want to get out of his own bed, and I was like, totally fine, but he really, really needed a mattress overlay because he was quite thin and his shoulders were uncomfortable. And then we realised that even though the overlay was only about 8 centimetres taller than like the other bit of the bed, his partner, Ross, he said, you know, Sarah, he's down a hole. I was like, okay. So we got another one and put it next to him. So Ross had to sleep on the squishy as well, but at least they were the same. Doorbells. Now, I don't know if you use these. Yeah, good. So there's doorbells from Bunnings, which you have, hardware store. They're available from one technology company in Australia as a switch adapted. So they've got the jack where you can stick any sort of buddy button in. But my husband's an engineer, so I went down to Bunnings and bought a bunch of doorbells and made him convert them for me in my kitchen. And we use them all the time now for people. Someone's got NIV on. I've got a whole other talk about managing comfort and discomfort and stuff with people with MND. And, you know, one of the things that I have seen a lot is this kind of level of stress. If someone's, you know, in the lounge room with their NIV on, or they can't talk and their loved one is in another room, there's this kind of like jiggling back and forward. And it gets really a little bit frustrating for all parties. And so being able to just call for help when they need to. This mount is from a company that I work for. But it means that it's really bendy and it can be just put anywhere. You can put it at the end or at the head. And it just means that everybody knows that people can get attention if they need to. Personal alarms, another thing that I think I talk about a lot, but making sure that it's the right alarm for the right person. They're all Australian websites, I'm really sorry. Home modifications. I know we were talking about this with Claire, and your funding's a bit tricky, our funding's a bit tricky too. So I do talk about considering non-permanent, cheaper, faster modifications, if possible, to be able to keep someone, to be able to live at home. And there are other concept that permanent home mods can be really, really disrupting. Having your bathroom ripped out, then you've got to look at it. The timing can be tricky, the disruption is tricky, the cost is tricky, and it can be psychologically difficult to have that going on. So I'll show you some of the things that we do, and I know one of these things is available in New Zealand. These are rubber ramps made out of recycled tractor tyres. They're measured up, cut to fit, plonked in place. Costs about 500 Australian dollars. Took the door off. It's not fabulous, like I had to kind of fight a little bit with the palliative nurses that they didn't like it, but it's what he wanted. He didn't want to have his bathroom ripped out. And his wife didn't mind that there was a bit of water on the floor. She just mopped that up. And it meant that he could have a shower when he wanted. And they can achieve really flexible ramp angles. This other one is like a component system that just gets clipped into place. The guy who on the shower there, he's got PLS. He's been living with PLS for 12 years now. He lives in an old prison in the north of Melbourne. It's cool, lives in Old Pentridge. He never wanted his bathroom renovated. He's like, no, I might move one day. Funnily enough, they have just moved, and he's now getting his bathroom done in the permanent house. But they never knew when they were going to move. So he was happy with that. Some slightly left of centre bathroom, showering modifications that we have used. So this is a portable shower thing called a care port, which can go in a garage. Portable shower tray for a guy that lived in a shed and was quite happy living in his shed, and that worked for him. That one up the top, the commode actually wheels off, so you can then use it over the toilet if someone only has a bath. And it's totally removable. So if someone lives in a rented house or they don't have any other option, that can be an okay option. And in Victoria, you can rent one. Ramps, same thing, Enviro rubber ramps. He makes them so they can kind of go around things. You don't have to like move air conditioning units and he can put an edge on it so nothing's going to wheel off. Wheelchair accessible vehicles. There's been lots of discussion in Australia recently with the changes to our funding about funding for wheelchair accessible vehicles, because weirdly enough, 10 years ago, we actually had some really good funding for the first time, and it was funding that was available for the first time ever. I've been OT 25 years and it was amazing, and now it's not there anymore. So we've been having lots of discussion amongst the OT community about how we help people who are in wheelchairs, who would like to be able to go places on their own time and not be stuck in using a wheelchair taxi that in Melbourne anyway really can be a little inflexible and a little inconsistent in when they turn up. We also discuss a lot about the sort of car hoists, and I think overwhelmingly we've found that they're probably only useful for a short amount of time, so we like to look at other options. We have now some wheelchair accessible vehicle hire companies, which can be a good option for people who need to use them for a weekend or a wedding or something where they don't want to have a vehicle for the whole time, but they need one for a little while. But you know, when we can get it done, it can afford some really great independence, and I try and facilitate it as much as I can within the person's means. The guy on the right here, this was a second-hand vehicle that I got from an ex-TAC, which is our Transport Accident Commission, because they get an upgrade every 5 years, and so the wheelchair guy was... And it came into the funding category. Like, I had 2 months before it was going to be ineligible for the funding, so we just managed to scrape it in. He even gets to sit in the front seat, so he's pretty happy. Energy conservation, I think as OTs, this is something I like to talk about. That philosophy that a shower chair is for people who's, you know, who can't stand up. And actually I'm like, well, if you're finding you're tired during the afternoon, if you can sit down for your shower, you're going to use less energy, so you have more energy for the fun stuff. So it's just about that moving around the energy a little bit and thinking about a little bit differently. And, you know, everyone will do what they're comfortable with. But we do have some information that we give out that is just people can take and read if they want to. I'm certainly not going to tell people what to do, but there's just ideas. Things we like. Slightly left of centre things. So bidets with foot controls, especially for people that have effects in their upper limbs. Drink holders, I was telling Claire about that earlier, that this is... the guy with the beer can sent this photo to me after we got this drink holder, and he was like, Sarah, this is like the best thing you've ever got for me. The guy here with the head strap, he can talk, and he just desperately wanted to control his mobile phone, but we couldn't get it to work with the Google Assistant because he used to have it on his lap. So we've just basically clamped it to one of those mounts with a phone holder, and it means it's at the right time, except he's still too polite to Google Assistant. It's like, hey, hello Google, would you mind awfully playing Tubular Bells? But we're getting there. I had to tell him he has to be more rude to Google. Straps for commodes. Now, this is a funny old thing. So 10 years ago, I had a guy who I'd been with treating for a long time, and he had just got a whole bunch of new carers, and he's in his Tilton Space commode, and he emails me using his old school Tracker Pro. Sarah, I'm really scared in my commode. I was like, okay, what is it? He's like, I don't know, it's totally irrational, but I feel like I'm going to fall out. These people don't know me, I can't move, and if I fell out, I've got no way of protecting myself. So I literally sewed some waterproof straps, which we strapped around him. Like, he wasn't going to fall out. Doesn't matter. He's like, great, I'm in, can't fall out. There's kind of a visual cue for my people looking after me, and it seemed to work. So just, oh, and I also made some neoprene-covered foot protectors. Satin sheets, help people slide around in bed a little bit, but you don't want the full satin sheet because then you end up like a bit like a turtle. You need some purchase through your feet, and it's just allowing your hips to move a little bit. I also do say if for the men or women have got any, you know, old, well, I say AFL boxes, but here it'd be like rugby boxes, satin boxes in the back of your undie drawer, they can work as well. Ear cutout pillows. If someone's got their NIV on and they like to lie on their side, sometimes it can really push on people's ears. We used to, I sound like really old. I used to cut out bits of foam with holes in them, but we've now found a couple of companies that do these ear cutout pillows, and they actually do a breathing mask pillow as well. Adapted clothing. Yeah. Call bell. This was a call bell in the hospital, so I've adapted a few of the switches we have in the hospital to be able to plug into our hospital system, because I just don't want to know that someone can't get help if they need it. And our, you know, hospital call bells are about this big. Not very useful. Anyway, so I've worked with engineering and got some adapted. So that's just a microlight switch, which I've got on a long cord plugged into the hospital system, or you could plug it into one of those remote call bells, and then he could just press it with his toe. Chairs that go around tables, really good for respiratory changes, to be able to facilitate some breathing. It tilts up. People can put their iPad on there so they're not sitting like all of us, like this, on our screens. And you know what I really like? I like working with my colleagues. I like working with the physios, the OTs, the nurses, the dietitians, the speechies, psychologists, music therapists, I don't know, all of them, the doctors. So yes, we like creative solutions, and we like to think outside the box, and we like to make the system work. So, as I say, MND is still incurable, but it's not untreatable. So, thank you.
Thank you very much. I'm going to have to hold you up on the Victoria, it's Otago, rather than, we get very kind of competitive about your different universities. That's all right. So thank you very much to the organising committee, to Claire and to Carl for inviting me today. As was mentioned, I have a joint role. I have a clinical role running a non-invasive ventilation clinic, and also an academic role within the Department of Medicine. So home non-invasive ventilation has been something that I've been interested in for the last 20 years. But it seems that we're still sort of banging on a little bit about the same things, which are to do with access, to do with fairness across the country. And so we decided that we would do some research to try and explore some aspects of this. I thought it would be useful also to cover why neuromuscular conditions lead to respiratory problems, the role that NIV has in helping ameliorate those, and also some of the research that we've been doing. This Tiha Ora is a Maori expression or phrase that means the breath of life, and I think it captures the issues around respiratory and motor neurone disease, and that to have respiratory difficulty with this condition means that you're experiencing daily breathlessness, and this has an enormous impact on quality of life. And some of the therapies that we try to provide provide the opportunity to help ameliorate this. It has been estimated, and this is on US data, that there are huge annual costs from having neuromuscular conditions, including ALS. And a substantial part of these costs, especially the healthcare costs, relate to respiratory diseases. So therapy that's directed at trying to ameliorate that or to help prevent some of those complications is likely to be very cost effective. Awake breathing requires the coordinated action of a number of different muscle groups, starting from the nose to the pharynx down to the diaphragms. And all of these are coordinated through neuromuscular junctions and actions. So you can see in ALS that you're going to get involvement with this condition. When we see a patient in the clinic with neuromuscular disease, they often start to develop a shallower breathing pattern when the diaphragm's involved, breathlessness when lying flat, and the chest wall becomes a bit stiffer, and if there's swallowing difficulties, they're more prone to aspirating small amounts of gastric acid. So the lungs are predisposed with the pathologies of motor neurone disease to respiratory difficulties. There are other also important functions in terms of cough, depth of breath, sighing, and swallowing that are all coordinated through muscular action. When you go to sleep, we see further challenges as the body goes to a more automated or autonomic part of the nervous system. And so CO2 levels tend to rise a bit during sleep, oxygen can drop, and the diaphragm, or the lung volumes, which are largely determined by the position of the diaphragm, that tends to drop a bit when you lie on flat. And so sleep poses a particular challenge to patients with neuromuscular conditions that are advancing. And in some individuals, you can see that we start to see, first at night, the failure to maintain normal levels of oxygen and CO2, and over time, the development of ventilatory failure. This is Neil Laddieman, who I know was a very important part of the Muscular Dystrophy Association and a big advocate of helping to promote the use of this therapy and explanations as to how to make it work. When we apply this therapy, we're using a device that delivers positive airway pressure at 2 levels, a higher inspiratory pressure and a lower expiratory pressure, that helps supplement the normal actions, particularly of the diaphragm muscles. So as you're breathing with NIV, it's attempting to coordinate its actions with your normal inspiratory timing. And it's been shown to help prevent this worsening of respiratory failure at night. It's been shown to reduce pneumonia and the frequency of chest infections, and to prevent in most the need to go on for tracheostomy. This study's been mentioned already, and it really helped, provide a good enough evidence base for us to argue for this therapy in MND patients in New Zealand. So there's a very important UK study that showed that survival and quality of life was improved in MND patients who presented with predominantly non-bulbar or only mild bulbar involvement, with this sort of set of symptoms, which we now kind of use as part of our screening criteria for who might go on to NIV in a clinic. We have been interested in the kind of community benefits of a range of patients who might be in respiratory failure, and we've studied what effects have been in our own kind of clinic populations. And in this study, we found that with NIV, nearly all patients experienced a positive response when they were in our home program. They felt that it helped them maintain their independence, it helped some stay at work, it allowed them to be in a home or community environment rather than under institutional care. But there were a number of issues that have been raised in terms of the access to this therapy, what to do, what the skill sets are like of the people that they're interacting with, and who to go to for help for this. Some of the important issues for neuromuscular patients are shown on this slide, and they include being at considerably higher risk during the normal procedures that you might go to hospital for. So having an endoscopy for a different reason, or a minor anaesthetic. If you've got neuromuscular weakness, these become much higher risk procedures. They see the value of multidisciplinary teams, and I'm lucky enough to be part of a good one in Wellington. They're concerned about the availability of backup power supplies. So what happens if the power goes out? What about battery backups? What about if my machine breaks? And also, of course, access to good respiratory care. At our clinic, we've now sort of evolved to, with technology, to having the data available from your NIV machine, shown here, wirelessly recorded on the cloud, and now downloadable to clinical programs that actually produce amazing information in terms of NIV care. So technology is shifting a lot of this information into a cloud-based environment where you can access key parts of it, but that data has to be looked at by somebody, the information has to be responded to in a certain way, and we don't actually have in place the resources at the moment to adequately monitor these and react to them. But we can remotely prescribe, we can record when things are going well, and we can make those changes in a wireless sense. It also shows the importance of having some sort of battery backup, and people have to be quite creative about this. often the car has got a source of a battery that you can connect to, and I've had a number of patients, when in trouble, have used their car battery as a form of NIV backup when the power supply is gone. There's also quite a lot of variability in terms of access to cough assist. Some DHBs can provide it, others can't. We see probably value in being able to access this in selected patients, but there are others who find that they can end up with too much equipment in the home environment. So it's a kind of very balanced question as to who needs it and when. We also try to advise patients about some of the interventions that don't work. And a few years back, I had a number of patients asking, or actually pushing me to refer them for diaphragmatic pacing. And diaphragmatic pacing has been subjected to some quite interesting, well, it's been subjected to a good randomised controlled trial, and it had good theoretical reasons as to why it might be helpful. But in the end, actually, the research studies that have been done in this showed that the outcome was poorer in people who were paced compared to those that were not. So it was an example of where research, and this was a multi-centred study, I think it was UK-based, showed a much poorer outcome if you were in the paced group when it was added to non-invasive ventilation compared to being on NIV alone. And so we don't provide that therapy, but it was very helpful to have good quality trials in which to advise people about this particular question. There are a number of useful resources that are available in New Zealand for respiratory care and internationally. Most of the clinicians use the sort of either NICE guidelines or the ENABLE guidelines for NIV. Neil, who was a patient of mine, has produced a really nice video as to how to use NIV in a home circumstance. I remember he reminded me of the importance on his wheelchair of, I think, was rabbit mode as opposed to tortoise mode, which he used to complete the Wellington Round the Bays half marathon whilst on NIV. So he was really incredible in terms of how he adapted this therapy to help him continue to use, to gain quality of life. There's also some important Canadian websites that are very helpful for NIV use. This CanVent study, CanVent website, is the one that's being promoted at the moment as being very helpful for both clinicians and patients in terms of the different phases of respiratory issues and needs, and then going on to finally being on non-invasive ventilation. At the last ATS meeting that I was at this year, the role of targets of clinical practice were being promoted. And this is where, instead of just thinking about one mode of therapy and adjusting the pressures to what people tolerate, to actually use the downloadable data that you now get from the new devices to generate targets for the depth of the breath, and also this thing called the ventilatory efficiency index, which basically is to ensure that you're not breathing too fast on your NIV device. So the aim is to have a lower frequency and a higher tidal volume to be achieving these kind of targets of therapy. So now to move on to the research that we've been doing. So we see NIV as being very valuable in motor neurone disease, probably in about a third of people. But we're interested in the more broader question of who's getting therapy overall in New Zealand, both neuromuscular patients and also the other conditions that we provide NIV for. So this was part of a body of research that's been funded by several grant providers, including the Muscular Dystrophy Association and the Otago Research Foundation. The first piece of research was borrowed from the MND PREV study, which is a muscular dystrophy genetics study where all patients with genetic neuromuscular disorders completed a very detailed questionnaire and blood testing and clinical typing. And in this study, they asked about the amount of those patients who were receiving ventilatory support, and not a very high amount, only about 15% of those were on some form of ventilatory support. So a national study, the vast majority were having this delivered at night, but there was quite a lot of variation across the different regions of New Zealand, with this dark colours here being the highest rate of NIV use, and these lighter colours being low rates. In 3 of the DHBs, there were no patients on ventilatory support. And also a second question in this research was whether you thought you needed to be on ventilatory support as well. And nearly 4% reported that they needed it but weren't able to access it. And a relatively higher rate of those people came from this Auckland DHB. So it's not just the smaller DHBs that might be experiencing this difficulty in accessing therapy. So putting this in context, we're also interested in the overall patient group on NIV in New Zealand. So we did this study where we surveyed all of the different clinical providers across 23 different DHBs, asked them who they were prescribing NIV to develop a prevalence rate for the whole country, and compared this to a study that was done 6 years ago, which was an Australia and New Zealand study done by Dan Garner when he was a research student in Melbourne. And what we found that overall this therapy has doubled in prevalence. So it's gone up from a rate of about 16 per 100,000 to 33 per 100,000 over that 6-year period. So much more NIV is being prescribed. But again, there's this big variation in the number of prescriptions across the country. And so this map shows the different DHBs, and you can see in the lighter colours relatively lower rates of NIV prescription, and these darker areas much higher rates of NIV prescription. So enormous variation across different district health boards. If you look at what conditions are being treated, you can see that the largest group are patients with obesity, hyperventilation and OSA. A big increase in the number of patients with COPD, obstructive lung disease, and about 15% have neurological conditions as the main reason for being on NIV. We collected ethnicity data as well and found that a fairly sizable chunk of Māori and Pacific were on NIV, but a large proportion of those are on it for obesity, hyperventilation. So we found what was mentioned earlier, which is that mainly Caucasian patients were on NIV with neuromuscular conditions. So this shows what's happened over this 6 to 8 year period. And you can see there's been a big increase in blue in COPD prescribing and relatively stable obesity, hyperventilation, and a relative reduction in the number of patients with neuromuscular diseases that have been prescribed NIV as a percentage, but the absolute number has actually gone up quite a bit as well. So as a relative percentage, it's a little bit lower, but the absolute number has risen. If you look at the different types between the two surveys, motor neurone disease is shown here, and you can see again as a percentage it's actually dropped to around 4% of the NIV prescriptions, but again the absolute number has gone up. For the first time, we've also been able to get data on this very important group of patients who have NIV dependency. And what that means is that you're using an NIV machine for more than 15 hours per day, and in some cases it's for 24/7, and we've never had data on this before. And so roughly 4% of Kiwis here are using NIV for more than 15 hours a day, so they're basically NIV dependent. This is showing the different DHBs that they come from. This is incredibly important information because we don't think that many of these DHBs are necessarily that well prepared for in terms of providing the backup and the other things that are needed for that to be something that goes without a hitch. We've also asked clinicians who are providing NIV services, what they think about the current services, by doing a focus group at the Australasian Sleep Association. And we did this because we anecdotally had a sense that many of these clinics were under quite a lot of pressure, without enough staffing, without adequate training, and in some cases without adequate access to equipment. Essentially that's what we confirmed in these interviews, that there was concern amongst these clinicians about the provision of things like battery backup, access to cough assist, the availability of equipment and funding, and that you were having to make difficult choices about who would receive what sort of therapy. We also found concerns about organisational issues with a lack of any dedicated funding, that the process was not always timely, that it was difficult in some DHBs to get through all of the barriers that were in place that prevented access to care. And there were concerns about the health system, the use of guidelines, their accessibility, whether they were relevant to New Zealand or not. So in conclusion, what our research on NIV is showing is that the use of this technology has increased quite a lot over the last 6 years. It's doubled. So that clinicians or the clinics that are providing NIV are doing it to a diverse range of different respiratory conditions. We're seeing large regional variation in the NIV prescription, and for the first time we've got a measure of NIV dependency across New Zealand. There's been an absolute increase in the number of patients with neuromuscular diseases on NIV, but also quite large increases in other conditions. We're doing this in an environment where there's quite a lot of barriers and constraints to healthcare delivery, and we're not able to sort of do the kind of wraparound health services that would be ideal for people, especially with neuromuscular conditions. I think that Kiwis like Neil Laddieman and their carers have to take a lot of credit for helping make their way through this, what is sometimes a little bit of a vacuum of support. So a can-do, kind of solve the problem, try and help sort out the issues that are there. If they have a breakage, they sort the problem out. In some DHBs, it's relatively easy to figure out what to do. In others, it's quite difficult. And the new technology provides both solutions and some challenges to how we deliver clinical services. We would like to see a national approach that's similar to what's been developed in the UK. I was talking to Anita Simons, who was at our ASA meeting last year, and they have a special package of care for people with neuromuscular diseases needing NIV, so they can access that extra funding and services. We have raised these issues on a number of occasions with the Ministry of Health, but unfortunately it's largely fallen on deaf ears. They've been interested to hear, nod, smile nicely, but they actually aren't doing anything about it. So I think there's a real need to keep pressure on the health providers to actually improve the overall provision for motor neuron disease, and especially the respiratory aspects of it. So I'll stop there and thank you for your attention.
Dr. Anna Miles is a speech and language therapist and senior lecturer at the University of Auckland, and also heads the Swallowing Research Laboratory at the Centre of Brain Research at the University of Auckland. Please join me in welcoming Dr. Miles to deliver her talk on motor neuron disease, the changing role of speech therapy.
Thank you for this opportunity. It's wonderful to talk about speech therapy anytime, but particularly in areas where things are changing rapidly, because academics and clinicians love that. So I'm going to focus mostly on swallowing and how things have changed for speech therapists working in swallowing, because Dean is going to come straight after me and talk more about the communication side of things, which is another area with plenty of change in recent years. Okay. So as we all know, a large number of people with motor neuron disease experience swallowing problems, either bulbar onset or later in the disease. And dysphagia is this term that we use a lot, and we need to be really careful that it's a symptom. It's not a disease or disorder of its own, and we sometimes describe it as if it is. But it really is just a symptom of something, and certainly a symptom very common in neurological disease. So dysphagia is not surprising, considering the upper and motor neuron changes that occur with motor neuron disease. And these upper and motor neuron changes lead to challenges across all aspects of that upper airway: the speech, swallowing, voice, breathing, and airway protection. And it's that common pathway that's led us to some of the things that we're now doing in this area. So these upper and motor neuron changes cover the whole of that upper airway. And we know that's a shared capacity between speech and swallow. That's our biggest problem, that airway sits in the middle of our food pipe. A crazy idea. And if I'd been able to divide them, I would. And of course, that means that it doesn't just affect the top, it's all the way through from the lips, through the throat, and into the food pipe. And as speech-language therapists and the rest of the multidisciplinary team, that means that we need to be considering swallowing across that whole system. And I'm going to talk about some of the things that sometimes we do that we forget about the other end, and end up with problems at one end that helped at the top end, but perhaps not at the bottom. And this is something we need to be really wary of as clinicians in this area. So these limitations affect safety, efficiency, and for many people in the first instance, enjoyment. We've all eaten way too much and drunk too much coffee today because it's pleasurable. So one of the most interesting areas in swallowing research is that of cough efficiency and airway protection. We've not typically focused on the cough itself, more on the tongue, the throat, strengthening those up, then things won't go down the wrong way, and then we don't need to worry about airway protection because things aren't entering the airway. Now we're realizing that our focus needs to be on that airway protection too. And voluntary cough strength is a strong predictor of aspiration and death. So if we look at forced vital capacity, we've got an indicator of swallowing outcome too. In fact, a forced vital capacity of less than 60% is a clinical sign of likely aspiration. And when we look at spirometry measures of peak expiratory flow, less than 4 litres per second, it gives you a 4 times greater chance of aspirating. So the worse you cough, the more likely you are to aspirate. And that makes sense. It's the same place that closes the airway as produces the cough and, of course, produces the voice. So what we often look at as a speech-language therapist, and this is the way I train my students, is this concept of safety, efficiency, and quality of life. So aspiration is a safety risk, right? If things go down into the lungs, or food goes down to the lungs, we choke, liquid goes down to the lungs, we might get an aspiration pneumonia. We know that's linked with death across all neurological diseases. However, slow meal times caused by subtle changes in the oropharynx lead us to diet modifications, so we might go onto a pureed diet, perhaps mealtime avoidance because meals aren't as enjoyable anymore, and that leads to malnutrition. So the efficiency side of things may lead more to the malnutrition, whereas the safety aspects lead to the aspiration pneumonia. So when we look at this, perhaps we give someone thickened drinks. So thickened drinks are well known to stop aspiration. So slower through past the airway, we don't aspirate it so much. But we significantly reduce quality of life because thickened coffee and tea is certainly not as enjoyable as our cold, nice drink of gin and tonic that we might have after today. So we may have solved safety, but we've reduced quality of life. And if we reduce quality of life, what happens? We stop eating so much, we get depression, we're not enjoying our meals, and we all know if you put people in residential care and make them eat socially, they eat significantly more than if they were left at home. And that's why many older people put on weight as soon as they reach residential care, because we eat socially. We eat far more when we're out than we do at home. So fix one thing and we have the chance that we reduce another. Another really good area to look at from this perspective is thickened fluids. Again, thickened fluids reduce more viscous, so they go through the throat better, so we don't aspirate them. They go through the food pipe slower too. And if we have food going through the food pipe slowly, we stop eating. We get full faster, we don't eat as much. So where we may have stopped it going into the wrong hole, we've left it in the food pipe long enough that that patient then feels full, eats less. And again, that's what happens with our over 80-year-olds. The food pipe slows down, they eat smaller meals, they adapt their diet accordingly. So we've got a relatively good amount of evidence about malnutrition in motor neuron disease, so thanks, Chris, for bringing this up. Weight loss is common, and weight loss is likely due to the dysphagia itself, so you have swallowing problems, so you lose weight, but also that increased metabolic rate that Chris was talking about, and certainly depression. We know that depression and weight loss are strongly correlated. But weight loss is strongly correlated with quality of life and with life duration in motor neuron disease. And so this is clearly something that people working in dysphagia need to be thinking about too. And as Chris says, there's some evidence that perhaps if we increase that calorie intake, we can correlate that with greater life duration and greater quality of life, which certainly is some area for potential areas for us to focus on clinically. So we've come quite a long way in what we do as speech-language therapists with regards to swallowing and motor neuron disease. And this incredible protocol came from the experts at the symposium in Boston in 2017, which some of you probably were there at the time and contributed to it. I'm going to focus specifically on the swallowing side of this protocol, but it certainly didn't just look at swallowing. So what they advocated for was more standardization, that there are some areas that we know now are predictors of problem, and we should be assessing them properly. And the first one is a self-reported questionnaire. So they advocated for every person with motor neuron disease to be taking a questionnaire regularly to map their symptomology of their dysphagia. And this could be done in their GP clinic, at their neurology appointment. It doesn't need to be done with anyone. It could be posted to them. But what we know is that this EAT-10, which is a really commonly used tool, if it goes over 8, you've got a 3 times greater chance of being an aspirator by then. So if we're mapping those patients, we're starting to see the point that they're most at risk. Or a motor examination, an obvious area for a speech-language therapist to check, and we now have more objective tools in our toolbox for measuring tongue pressure strength than we used to. Oh, I'm ahead of myself. Cough strength. So I said this is a strong predictor of aspiration. So now every speech-language therapist should be testing cough strength as part of their swallow assessment using a cough peak flow. This fabulous group, under the guidance of Emily Plowman, who was in Perth, so many of you may have heard Emily talking, have done a lot of work in this area of cough research. And they tested the cheap digital peak cough flow against fancy spirometry equipment and found that it was just as sensitive for this area, which is fabulous because it means that the speech therapists only need to pay out $40 for a digital cough flow meter to get the same result. And then they've got that predictor of risk from the cough result. And, of course, some sort of swallow safety test. We've been using the water test for decades in neurology. It's still in there, along with, obviously, our more instrumental assessment approaches. I'm not going to talk about this much because I really want to talk to you about swallowing rehabilitation. But as Chris said, tube feeding is used in people with motor neurone disease. So I'm just going to run through my perspective of the literature, which luckily wasn't different to Chris's, because that would have been awkward. So there are a number of retrospective studies that looked at this, and it looks like across the board around a 10% tube feeding rate, which I'm not convinced all of our countries would think that's what we have, but perhaps we do. 10% seems quite low to me. And these authors found that the people who were tube-fed had greater comorbidity, which is not surprising because that's probably how we're using them rather than anything else. But interestingly found that it did not make a difference to how many times they ended up in hospital with hospitalizations for aspiration pneumonias, which I guess we would guess too. They suggested that perhaps there was a more quality of life benefit rather than a safety benefit from using the tubes. And I think that is exactly what this qualitative research project, it seems to move on for me when I'm not quite ready for it. This qualitative paper that interviewed patients really did sort of show that it was a reduced worry for people who were tube-fed rather than improved quality of life. They felt less concerned about getting their medicines in. They felt less concerned about the push at every mealtime to get the meals in, to keep up the weight. And they felt that despite increased complications and tubes getting blocked and time taken to take a tube feed that was outside of their social life. So I think there's definitely a balance in that literature that we haven't quite decided what to do with. This meta-analysis and systematic review that was published just this year, they actually concluded that PEG use stabilized weight and increased survival duration, which is interesting. They also did not find that it made a difference the time you put the tube in to the duration that they lived, but I'm not, I think the literature definitely has a long way to go before I feel completely comfortable by that. But they did find that force capacity, if it got less than 50% at the time the tube was inserted, made a difference to how long they were going to live. So there's a point there perhaps around too late is too late, and you're not going to get the benefits from that PEG if the force vital capacity gets down to a certain level. But the biggest change in the management of swallowing disorders over my career has certainly been early proactive treatment. So traditionally, when I trained, we were trained to restrict diet, to encourage use of suctioning at home for saliva management and tube insertion, and they were our primary approaches. Now we're moving far more into an early and proactive approach in our research, and I think it has huge promise. Aggressive weight management and swallow rehabilitation are gaining stronger and stronger evidence base. So the aim of swallow rehabilitation is to improve physiological reserve with the goal of maintaining and prolonging good quality life. However, what we've found in clinical practice and in some of the research designs is that there's this lovely second stage of this, which is empowerment, that by giving people this approach of I can choose when I do this and I'm being proactive and working on my physiological reserve myself, that empowerment leads to a strength in mindset that means I can do something about my system, I can boost it, I can make a difference for myself. So the theory behind rehabilitation and motor neurone disease from a swallowing perspective is the concept that both upper motor neuron and lower motor neuron changes lead to reduced strength, inevitably, and a need for increased effort, so that swallow mechanism takes more effort to maintain safety and efficiency. And that's across that whole aerodigestive tract. And that leads to the reduced physiological reserve. So if that physiological reserve can be increased through resistance exercise, swallow, breathing, and airway protection has potential to be maintained at a safer and more enjoyable mealtime level, and therefore hopefully also improving health. So in the last 5 years, a number of studies have come out proving the effect of resistance exercise on the swallow, primarily out of Emily Plowman's lab, the University of Florida aerodigestive lab that Emily runs. And they've been looking at this area of expiratory muscle strength training. Now, this is a research lab that focused a lot on cough, so it wasn't surprising that they took this more respiratory swallow approach to their rehabilitation. Now, this is the EMST. It's a very, very simple little device that you blow forcefully out into, and it has a calibrated tube that's adjustable for resistance. So the idea is that as you rehab, the resistance is adjusted so that it becomes tougher. So it has a progression approach to it, which is quite hard to do. I mean, sometimes we've had researchers get beautiful cartoon pictures of the tongue with weights on the end. It's quite hard to add resistance to a swallow mechanism compared to an arm or a leg where you can pick up a weight. So this was a way of getting resistance into the exercise program. And Dr. Plowman and her team have demonstrated that it's well tolerated in people with motor neuron disease and that they can get positive results of expiratory muscle activity, swallow physiology, as well as reducing aspiration and residue in the pharynx. And if you think about that concept that one of the big issues here is cough strength and airway protection, an exercise that not only strengthens up the throat to clear things through, but also strengthens up that airway protection mechanism has a benefit. So Emily's certainly a pioneer in this field, and she's moved beyond that proof of concept into trying to optimize dose and timing. And some of her earlier work found that people with motor neuron disease who were in her trials, who were a bit later in their disease, dropped out, had transport issues, or as we were talking about earlier, was struggling with the lip seal over the device. And so one of her arguments with that is that early intervention is better because it prevents that issue. So she's advocating for early in the disease. They've also experimented with this concept that the reason we didn't rehabilitate motor neuron disease was fatigue and the speed of degeneration of those muscles. So the EMST program that's been developed for Parkinson's disease works on a 70% load of resistance 5 days a week for 5 weeks. So Emily felt we needed to reduce that load to reduce the risk of fatiguing muscles beyond usefulness. So she has been experimenting with a 50% load for 8 weeks, so a longer period but at a lower load. And it's looking pretty good. So one of the things that they did recently that makes me more convinced by that idea that the dose is right is that they tried an inspiratory, expiratory muscle training combined. So they did a bit of physio, inspiratory training as well as the expiratory training. And in order to avoid double dose leading to fatigue, they dropped the load of both to a 30%. And their results are not as good, which is really interesting, which suggests that low intensity exercise isn't enough, but perhaps high intensity exercise is too much, and that moderate load is a better load for us. Now, these are quite novel ways of talking for speech-language therapists. We haven't necessarily looked at dose very well in our profession. We're very good at looking for new techniques, but not necessarily looking for what's the optimum dose to give a patient. So this is really exciting research for us in this field. Now, another area that is just beginning to get some attention and has certainly been well researched outside of motor neurone disease is tongue resistance exercises. And this is actually the little model that we use. This is the device we use to assess tongue strength in our assessment protocol too. And in this case, it's a resistance-loaded air pressure bulb that people press against. It's very much in its infancy and certainly not something that we've proven works in motor neurone disease, but certainly works in healthy elderly, certainly works in Parkinson's disease and stroke and head and neck cancer. So it has definitely got potential to be an area for the future for people with motor neurone disease too. But for the moment, this is the only device we've got currently that has been tested exactly in this population. So from a swallowing perspective, in summary, the evidence base is looking really positive for us, for actually stepping in there and doing something rather than just being there when things have gone very wrong. And this means that our multidisciplinary teams need to think about how to use speech-language therapists in a different way too, because the way our service delivery models work currently, we're often last in when things are very bad, when people have started to get into hospital with aspiration pneumonia, when people think a PEG might be needed, and certainly not right at the beginning to try and prevent things from getting worse. So the way that I'm advocating with the speech-language therapists is that they get in to their teams and talk about this sort of research and demonstrate that there's a place for us earlier in the piece, that they get in there with standardized assessments that include a cough strength test so they can start looking at that area, that they're getting early swallow rehabilitation and early work with the dietitians for looking at nutrition and weight loss, and that perhaps we're still going to be using those PEGs. Hopefully we can get to a point where we don't need them, but for the moment the PEGs, maybe there is a good support for weight maintenance in the later stages, but that we try and hold back the progression of that reserve as much as we possibly can. So thank you very much.
So Dr. Dean Sutherland is a senior lecturer in the School of Psychology, Speech and Hearing at the University of Canterbury, where he also chairs the university's Human Ethics Committee. Dr. Sutherland's presentation today, Communication, Best Practice and Voice Banking Technology, summarises current research on best practice communication support for individuals with motor neurone disease. Dr. Sutherland will be assisted by Emily Logan, who is a speech and language therapist at TalkLink. So let's welcome both Dr. Sutherland and Emily to the stage now.
Kia ora koutou, nau mai haere mai, ko Dean Sutherland tōku ingoa. That's a greeting to all of you. My name's Dean Sutherland. Who breathed a sigh of relief when it was mentioned I wasn't going to talk about ethics? That's a whole other field, but I'm not going there today. I'm going to talk about one of my favourite subjects, and that's communication with people who have great difficulty with communicating at various stages of the illness. Firstly, I'd just like to acknowledge Emily, who's with me. And you'll hear very shortly from Emily. Emily is a practitioner who works with TalkLink, a national assistive technology provider, and she's going to have some great stories from the field and also some reminders for New Zealand-based practitioners in the room. Acknowledgement also to Claire, Lydia and the MND team for organising this. Fantastic to be here today, to hear particularly from both our national colleagues and our international guests who must have wondered when they said, yeah, I'll just pop over to New Zealand from Perth, no problem, just next door. And then you got on the plane, looked at the map and realised, I feel for you. I married an Australian, a Perth native who made me sign a document that says we'll go back to Perth every year. I go next Sunday. But I'd particularly like to acknowledge the people in the room who are living with motor neuron disease, whether that's yourself or family members. You're the reason we're here, and you're the reason that sustain the work that we're doing in this room. So thank you, and we're with you all the way. Right. I work in the College of Science, and when I'm saying I'm a speech and language therapist, people look at me funny. I always talk about Stephen Hawking and say he's one of our greatest advocates, and not so much for his scientific discoveries, but for how he has communicated those discoveries with us. If it wasn't for some of those speech language therapists, communication specialists, occupational therapists in his world, we may not have learned about those discoveries. What I'd like you to do, take 1 minute, it's that time of day, I'd like you to turn to the person next to you or someone, and just for maybe 30 or 40 seconds, I'll time and then I'll tap the microphone. Talk to them about something that you're looking forward to in the next 24 hours. Go for it. Sorry about the rude interruption. I hate breaking up, but we've got a time schedule, there's planes to catch and that sort of thing. Same thing again. But this time, you are not able to use your voice. I did that for a couple of reasons. One, it's 4 o'clock in the afternoon to wake you up. But to give you a little bit of insight, I'm a big believer about perspectives. And as a therapist, as a researcher, I think it's imperative that we put ourselves in our clients' shoes from time to time and realise what it is like, so that what we provide them hopefully better meets their needs. Some terminology, AAC. AAC is any form of communication we use that is not our voice, essentially. That could be unaided AAC, which are hands, facial expressions, eye movements, those sorts of things. Aided AAC is a pen and paper, a device that has a voice, a text-to-speech voice output with it. We have to have the light writer up there, don't we?
Everybody loves a light writer.
Exactly, I'm with Sarah. Yeah. The Megabee, another great form of communication that can be really useful for people who have lost the ability to speak. We're going to talk a bit about voice banking, a bit about message banking, and particularly Emily's going to take us through some of those things, and some research we've done in New Zealand recently about getting some Kiwi accented voices available, which has been a long time coming, because in case you didn't notice, we speak English, but not your English if you're not from here. We speak not the Queen's English, someone else's English. We know that if you have a communication impairment, there was some research out of Canada back in 2008 that showed that if you have a communication impairment or difficulty, you're at 3 times more risk of having an adverse medical event in a medical institution. So communication matters for your well-being. If you have MND, around 70% of individuals are likely to have some communication challenges at some point in the disease. But we know everybody, you might have the same label, but we know from our talks today that everybody is different. Everyone has different needs, everyone has different physical challenges through the course of the disease. But we know that AAC can help meet many of those communication challenges. And we've heard about the psychological and social issues and impacts, and again, they vary from individual to individual. A great example of that is we look at the high-tech systems with voice output. They look sexy and everyone wants one. Well, actually, not everybody wants one. And there's good reasons they don't want these things, and I'll talk a bit more about that shortly. Sarah's nodding.
Oh my God, you're talking to me.
Yeah. If I forget at the end of the talk after Emily, I've got a little story about my mum. Related, very much related to this. We need to provide options. We need to think about access needs. And it's duplicated there unintentionally, but maybe it's relevant because access needs change all the time. And subtly, with fatigue, with medication, all these other things that sometimes are a little bit invisible to us. This word cloud was created by a group of Year 11 students at Canterbury University last week. We had them in. I said to them, what's important to you, but what does communication mean to you? And these insightful Year 11 students came up with some really cool things. Does anyone know Augie? Augie's got a cool YouTube clip that highlights some aspects of communication.
ALS presents many challenges, but communication is the most overwhelming. When the ability to communicate is lost, hope often goes along with it. Not only do you lose your voice, in a sense, you lose your identity. When I was diagnosed with ALS almost 4 years ago, I knew that I didn't want that to happen. And when I was starting to find it harder to move my hands, I started to explore software and hardware solutions that might help me stay connected with my friends, family, and business colleagues. Today I stay connected with my eyes. Eye tracking technology used to be confined to university research, but thanks to Dynavox, it is now real technology that solves real problems. With my eyes, I can speak, send email, control my environment, TV, DVD, etc. with infrared controls, use the internet and read books. This device has given me the power of hope. More than 90% of people diagnosed with ALS lose the will to live and elect not to go on a ventilator because they cannot communicate. It is frustrating because although my body may not function in the manner that I want it to, my mind is sharper than ever. The VMAX and IMAX give me the ability to connect with others again. As you can imagine, this is extremely powerful and has given me the ability and will to live. The inability to communicate is not only difficult for the individual living with the condition, it also presents concern for loved ones. I have been fortunate to share this journey with my wife, Lynn.
I think as the wife of someone who is having a harder time communicating, as you're not able to communicate as well, it gets very lonely from a caregiver's perspective, from a family perspective. And because of the Dynavox and the IMAX, Augie can talk to me, we can still have conversations, we can still share. For Thanksgiving, he took it with us to his sister's house, and where usually he would be sitting there and no one could hear him or understand him, he was able to talk and play around with the kids and joke around. I think there's a tendency for people not to want to come.
A real reminder there of the power of technology. There are some barriers to technology, and I'll just make a point about that. That's an older system. There are better systems around these days, but it's a great clip to show you the benefits of the high-tech communication eye gaze. That technology won't work outside in the sunlight, for example. So how do you communicate in that situation? And that's where we need to have multiple communication options available. We'll see another one of those shortly with Emily. Interesting story, communicating with somebody who was using one of these systems. I asked them a question. I got distracted, my phone started buzzing, went out of the room, got distracted, 10 minutes later went in and they were just about to press the response to my question. Reminder, it takes different ways of communicating. The dynamic that we have of very agile verbal communication changes when we're communicating with somebody who uses a communication system such as this. And it's really important for our communication partners to be willing to change the way they view communication, the way they interact, the way they listen. Listening is probably one of the key things to supporting people to communicate with these types of systems. I'm going to just play some examples now. So the voice you heard there was a system-generated voice based on the text that Augie was inputting into his system. In New Zealand, for many, many years, people have been listening to British or American voices on their communication systems. I've heard many individuals express to me the frustration with that. We've recently been able to speak Australian, which for some is a positive move and some's not such a positive move. Equally frustrating. We now have voice banking technology available for people who can utilise their own voice to create a system-generated voice that is based on their own voice. And here's an example of one. So this research involved healthy voice donors donating their voice using a model talker voice banking system, which is out of the US. Nema's Speech Laboratories, Tim Bunnell and the team there. Listen carefully because it's not the easiest
voice banking. This involves recording a large inventory of speech that is then used to create a synthetic voice that approximates natural voice. This voice is based on a 40-something-year-old female native New Zealand English speaker.
Intelligible? Yep. I know this person and that sounds like her. And that's her voice. This next one.
Phrase or message banking is the process of using a digital voice recorder or computer recording software to record and store words, phrases, sentences, and personally meaningful expressions in one's natural speaking voice.
That was me after one beer, late one evening with a pretty low-tech digital recording device. But again, that's message banking, and Emily's going to talk more about those things now, and I'll come back to join you at the end.
Thank you, Dean. So voice banking is an umbrella term that can be used to talk about all three of these things. So it's just an opportunity to highlight their differences, pros and cons for each one. It gives you a good example of how they each sound. So as Dean mentioned, voice banking is recording a large inventory of sentences, and then software generates a voice based on the person's natural voice. Of course, you lose prosody, intonation, as you've heard with those two different examples. So phrase and message banking has more of a place for things like terms of endearment, things like the lovely Bob, Bob, Bob example that Sarah used for her person she was working with. People that we've worked with at TalkLink, where this comes up a lot, is for things like banter between families. I was working with a lovely man who lives with his brother, and being able to banter with his brother in his actual own voice, as opposed to something that's synthetic, whether it's a synthetic version of his own voice or another synthetic voice, was really, really meaningful for him. And story banking is similar to message banking, but it's larger chunks of things, which can be, you know, story of someone's life, information about themselves. There was a lady I was working with who got a diagnosis of MND, and the biggest concern for her was that she was worried about never being able to read to her granddaughter, who was a toddler at the time. So she used story banking to record whole chapters of Roald Dahl books, with the knowledge that then she would still be able to read to her granddaughter, no matter what the progression of her MND was going to look like. So yeah, process similar to message banking, favourite stories. It can be things that are very personal. And also this is very much future-proofing. It's something that can be done at any point until, depending on the progression and different techniques as well. Also using voice donors. I know that the research that Dean has done with Model Talker allows for that as well, where someone, so it might be a voice donor who is preserving the voice to then create it into a synthetic voice. So let's see if this works. Yeah, great. So a little bit more about voice banking. These are the different, let's see, these are the different companies and ways you can go about voice banking. As an example, Model Talker requires 16 to 1,700 phrases to be recorded, quite time-consuming, 6 to 11 hours for a healthy voice. It is the one that we have sort of been using the most in New Zealand in recent times. A cappella group are also, they now have a service called My Own Voice, which essentially allows the person to create a synthetic voice from a message bank, so a lot less time consuming. There are things like it's not requiring such a sensitive auditory environment, but there are also issues in terms of pricing and funding avenues and things like that. Speak Unique is a pilot project that's happening in the University of Edinburgh, which is using more of the donor technology. So on the website they describe that as like a colour palette if you're going to paint your house. So there might be the person's voice, there might be donor voices, and then obviously the process of making that into a synthetic different voice. So there's different ways to go about voice banking. It can be done either by a person with MND or a family member. A variety of companies. It's not for everyone. It is a very sobering and confronting process to go through in terms of just coming to terms with the potential that that will be needed down the track. And some of Dean's research also highlighted that voice donors can really enjoy that process as well. Let's try that again. There we go. So several communication options. Absolutely loved hearing what Sarah was saying as well. There's a lot of overlap here in terms of all the different, no, it's great, that's absolutely fantastic, in terms of all the different things that are available. There's a huge range of high-tech communication systems, low-tech communication systems. You know, just the different stylus options that our OTs use is absolutely incredible in terms of all the things they come up with, some of them who are here in this room today. So pen and paper whiteboard, using a good old school 90s Magnadoodle, establishing a yes, a no and a maybe system can be hugely, hugely powerful. Having a maybe because the way the question is phrased may be incorrect or it might need clarification. We'll talk about partner-assisted scanning. I think there's a video that will highlight that quite nicely. So use of eye blinks, 1 blink for yes, 2 blinks for no, turning eye movement, a right looking to the right side of the person being a yes, the left side being a no, using an alphabet board or a picture board, something for meal times, or a board where there's different icons that maybe are around turning the TV up and down and talking about what you want to watch. It can be specific to anything. And then access methods are a whole other area where, again, us as speech-language therapists, we would be lost without our occupational therapists to help us figure out what is the best way for that person to access their device. It might be using a head pointer. It might be using a chopstick stylus attached to a head wand. It might be using eye gaze. This is a Megabee device which the person holds, so the communication partner is looking through the hole in the middle, and the person is then looking at letters, and you, as the communication partner, you press different buttons, and then it spells it out down on that screen there. So it's an example of an eye gaze system. There are other eye gaze systems. Infrared eye gaze technology is absolutely incredible now, and that enables a lot for people as well. Even just taking, a piece of perspex and attaching visuals in different parts of the perspex that have a hole in the middle similar to that. So really problem solving and again what you were saying, Sarah, making it about that person and what they're going through, what their needs are, what their dexterity is like, and really making a decision based on that and sort of erring away from shiny object syndrome. The tool is the last thing that comes in that decision-making process, given everything that is available. And I think now we're going to watch another video, good for this time of the afternoon. And if I just do... So this is an example of partner-assisted auditory scanning.
Harvey Frank has ALS, amyotrophic lateral sclerosis. He is not able to speak and uses special systems and strategies in order to communicate. He does not have the ability to move in order to directly point to the letters of the alphabet. Instead, he uses a special system called scanning, which allows him to select letters without moving. With scanning, the letters of the alphabet are arranged in a grid. Here is an example of a vowel-based scanning system. The first letter of every row is a vowel. The communication partner will start by calling out the rows. For example, is it row A, E, I, O, U? Let's start again from the top. Is it row A? The person indicates that they want row A. Is it A, B, C? The person indicates that it's letter C. They have just selected a C. Harvey and his attendant, Silva, are so familiar with the layout of the alphabet chart that they don't need to have it in front of them. A person can use whatever movement is easiest for them to indicate yes. It can be a head nod, an eye blink, or a glance in a certain direction.
Okay, I think that's, and if I do that. So yes, that's an example of partner-assisted scanning, and again, where that yes-no response is so important. These things take time, as Dean mentioned as well. You can see how communicating using that access method and that sort of system is obviously a lot slower than verbally speaking, but the benefits and the reason for doing it is definitely outweighs the challenge in terms of the time constraint. So I think, yeah, Dean's going to come up and join me to help speak about this slide. So social and emotional adjustment is, you know, one of the big challenges around using all these AAC systems, timing of the support, what are the environmental factors, what are the communication partners, family members, friends, professionals, who is involved, who is communicating with that person, breakdown, and this kind of leads into the whole high-tech versus low-tech chat, which, you know, could talk about for an hour in itself. So high-tech devices are great, but they break down. Can't use them at the beach. It's really difficult to use them if their batteries lose power, and then what happens? And just the continuous, how the technology is always evolving. So at the TalkLink Trust, our team of speech therapists, occupational therapists, technicians and teachers, our job is really to, well, do our best to keep our fingers on the pulse in terms of how things are changing and what is available. Getting us on board early. So TalkLink hold the contract for assessment and training with the Ministry of Health and ACC to provide assistive technology to anyone that has a communication disorder. And anyone can refer to us. We're a charitable trust. We aren't a for-profit private organisation. It's of absolutely no financial benefit to us whether our clients end up getting a system funded, whether they use a low-tech book, high-tech device. Our job is merely to show you the options and to let you know what's out there. What else? I think that's it.
60-second story. My mum would be remiss if I didn't share this with you, but for the last 3 years of her life, she was locked in. She had locked-in syndrome due to cortical basal degeneration, presented very much like motor neuron disease and whole disease progression. We used partner-assisted scanning to communicate for 3 years. There's no place for ego when you're a communication partner of somebody using the system, and this is just one example of that. Row A, E, I, J, K, L, got it? A, E, I, O, O, L, O. Ego. She wants to tell me she loves me. Oh, let's work through. I won't predict. Let's work through the system. A, E, I, O, U. Yep, row U. Letter U. Yep, U. That's not how you spell love. What? L, O, U, D. Louder. She wanted the radio louder, but I was thinking Mum was going to tell me she loves me after all these years. But so, leave the ego at the door. Thanks, guys.
Thank you.
Our final speaker for this session is Professor David Oliver, who has recently retired from the full-time position as consultant physician in palliative medicine at the Wisdom Hospice in Rochester, Kent, and is an honorary professor at the Tizard Centre at the University of Kent. Professor Oliver, who I've worked with for many years, was clinical lead for the National End-of-Life Care Programme document, End-of-Life Care in Long-Term Neurological Conditions, a framework for implementation. He was the chair for the UK National Institute for Health and Care Excellence Guidelines on MND, released in February 2016. Professor Oliver has also very kindly given his name to the annual MND New Zealand Award, the David Oliver Beacon Award, which recognises individuals or organisations that have made a positive contribution to MND support or care. Thank you.
Thank you very much, and thank you for inviting me over to New Zealand again. Very pleased to be here. What I'd like to do is just talk about palliative care, and at the same time, we may raise issues that need to be looked at for research. So what is palliative care and the various aspects of assessment? I'm sure you've all seen the definition of palliative care, the World Health Organization definition. Every single word is important in this definition. It's an approach that improves the quality of life of patients and their families, we've heard of so much today. Facing problems with life-threatening illness, I think we can all agree that MND fits into that. Through prevention, relief of suffering, early identification, impeccable assessment of pain and symptoms, psychological and spiritual issues. So where are we? We need to think of what palliative care actually means to all of us. And I think there's a variation in people's understanding. The European Association of Palliative Care tried to think of 3 levels, that every doctor, every nurse, every allied health professional will be providing palliative care for all patients at all times. It's good care, it's listening to patients, helping them to make decisions, helping to involve families. For some, professionals, they will need to provide generalist palliative care, and that's where I think many neurologists will be involved in providing palliative care on a regular basis with perhaps some training, some extra expertise. And there's specialist palliative care, which as a palliative care consultant I was providing for the more complex issues. And increasingly, particularly in the States, there is now discussion of neuropalliative care, neurologists with extra training in palliative care. So what are we trying to do? We're looking at all the different aspects of care. The physical, the symptoms we've talked about a little bit today, positioning and mobility we've hinted at today, the communication issues we've certainly talked about, the psychological and emotional, the social and spiritual. I'd like to look at each of those just for a few minutes separately. If we look at symptoms, there are many symptoms. This was a survey I did back in 1996 of the patients I've been involved with, but many symptoms. And there hasn't been a lot of research on many of these. If you look at pain, the use of opioids in pain with people with MND, the Cochrane, I was horrified, the Cochrane survey actually had most of the papers were ones I had produced 20 years ago. There, we can say that there is evidence that morphine helps with pain, but I can't say it doesn't shorten life or the best doses or the best way of using it. I can't say that because there's no evidence. Constipation, there is very little on constipation in MND. So we need to be looking at all those aspects. And one of the pleas I'd perhaps say is we've heard a lot about large expenses on research on drugs. But there is the need to look at the care issues. It won't be as expensive often, but it's important to look at how do we care for people, how can we have the evidence to show other people that there are treatments, management ways that we can help patients with MND. And particularly difficult if you are thinking of the psychological aspects, the fact that patients are facing these multiple losses, the cognitive changes, emotional issues, the fears of death and dying. Quite complex areas to actually look at qualitatively, listening to patients, listening to families, but very important so we can understand some of those issues for that particular person. For family issues, the changes, how do families cope with the changes in roles? How do they cope with the losses? And I was always pleased, there's always the OT who will talk about sex. OT's quite good at talking about palliative care doctors, death and dying, no problem, but we're not so good on the sex. How do we need to have those discussions, to have more evidence. How do we help people? When I wrote a book for families and patients with MND, the only comments I've had back are on 2 paragraphs on sex. And one patient said, we now go and do a Dr. Oliver, which I'm not quite sure if I want it to become a regular thing. The fears of the disease, the things about death and dying, about finances, about emotional changes, areas that we know, but can we find more evidence, more things, ways to help manage some of those aspects? And even more complicated when you start thinking of spiritual issues. There's probably no RCT on spiritual issues. But how do we help people talk about, and it's not necessarily religious aspects, it may be the why me. as we were hearing this morning, the why me may become an easier or more difficult for people to discuss. It's my mother or my father or my genes. That's why me. So it's really big issues, the fears about death and dying. And those are two different aspects. I had one lady who said, what's going to happen to me? And I was all ready to tell her she was going home next week. And she said, what's going to happen when I die? You know, I hadn't got an answer. I could know that we hoped how she would die, but I wouldn't know what happened afterwards. But we could talk about what her particular fears were, what she was concerned about. And I think in the communication, there is, how is that diagnosis told? We've just repeated Sam Ayoun's work in Australia, in the UK, and found that over 40% of patients said that they were dissatisfied with how they'd been told the diagnosis. It was much better in the specialist centres than out of the specialist centres, but it's a real issue of how do we improve that. We've been hearing about how people can cope with loss of speech, but cognition, I think, is an even bigger area. How do we discuss dying and the end of life? In the NICE guidance, we've said we would recommend that people are open to discussing end of life at any time from diagnosis onwards. For some patients, it may be at diagnosis. For some, it may be as there's a particular intervention, or it may be later, but we need to be open and hearing people's asking those questions. And increasingly, we're having discussions about hastened death, and I know that may become a real issue come 2020 in New Zealand. If you have a referendum and it's positive and then legislation, you will be facing patients asking for a hastened death. We were hearing in Perth that in Belgium, 23% of all MND patients have euthanasia, and it's similar figures in Holland. So it's an issue that we need to be aware of and listen to. Why is someone asking? And it may be the fear. And I think over the years we have more and more evidence to say that dying from MND is not necessarily a distressing, horrible death. It's copable with and is no worse than cancer or other diseases. But the internet often says very different things. And I think the issues of cognitive change, of how decision-making happens, how we've heard about communication to help people make decisions. How do we help someone whose cognition is not allowing them to make a decision? How do we try to get their views? How do we cope with the risk-taking? And how do we help families with that? I remember one lady who, when her husband said, we'll go to the shops, had put her coat on and was ready at the door within 10 seconds. And he kept on saying, we're going to the shops later. And he had to learn to say just before they were going out, rather than having this agitated lady standing by the door. So it's how do we help people in that cope with language and communication issues in those stages. And I think there's the same issues on professionals. There's very little about how we cope as professionals with cognitive change. How do we assess symptoms when we aren't able to be sure what someone is saying? How do we maintain safety? How do we help with decision making? Do we try to have more advanced care planning earlier on in the disease progression so we can get to know the person's views while they can still make that decision and communicate it? And I think that's one area where there can be very big differences within a multidisciplinary team. We all assume we understand the same things, but I think cognitive change can be the one area where there can be real challenges within the team of how we understand someone's cognition. And it brings me on to ethics. How the ethical issues, sorry, I know Dean said he wasn't going to mention ethics, but I am. But there is again, little research and evidence of how we do that discussion about MND. I'm thinking of the diagnosis, the genetics, where we talked about the need to have more information about the genetics, but how does that affect people? How do we have those discussions? We find out that the person has an abnormal gene. The ethical implications of the family are enormous. We have a case going to the courts in the UK with a Huntington's patient, who the man who had Huntington's said he did not want his family to know, and his daughter is now suing the health authority because she had a baby and she didn't know the diagnosis. And there's going to be enormous issues about the confidentiality. And I don't think, do we talk about that? Do we think about it? Do we look at that? How do we look at starting of interventions? We've talked about PEG involvement, insertion. What happens when that's discussed? Do we think at that time to say what's going to happen later? And in the NICE guidance, we were very clear when starting non-invasive ventilation, there should be discussion about stopping ventilation. Because we know that people are going to carry on deteriorating, and we are going to face people who are saying, I want to stop. Let's discuss that before there's a crisis, before the person is in the accident department at 3 o'clock on a Sunday morning where no one knows them, and a tracheostomy is performed because it needs to be done, but without any knowledge of that person's views or what they wanted. And we're into the issues of invasive ventilation tracheostomy, how is that discussed, and also in withholding and withdrawing treatment. And in the NICE guidance and also in the European Association of Palliative Care and the European Academy of Neurology consensus document on palliative care in neurology, we talked about how communication needs to be open, that we need to set goals, and we need to look at advanced care planning. The Brits, I don't know about Kiwis, but the Brits are not very good at that. We try and, it's always next week. I talked to a group of respiratory physicians and said, how many have made your will? And about 10 hands went up. And I had an email the next day from the person who organised the conference saying, I've been meaning to make my will for the last 25 years, and it was always going to be next month. I've actually made the appointment for the solicitor now. We're not very good. So how do we encourage that? But we know that it's going to be much more difficult to communicate for many, cognitively or physically. And I think all these issues, we do more interventions, and we have to think what happens ahead. This was a man with non-invasive ventilation who said, I wish I hadn't had this done. I now no longer can speak. My swallowing's difficult. I can't get about. What's going to happen? So we're going to have more people saying about withdrawal. And we have done research in the UK showing that the doctors, the nurses, the allied health professionals have found those discussions about withdrawal of treatment very, very difficult. They've all said, up here we know, we've read the ethics, it's easy, the ethics, someone asked to have a treatment that they no longer want withdrawn, that's easy, ethically. But they say the heart bit said something very different when they came to press the button and stop the ventilator. The heart was saying you pressed a button and the person died. You killed that person, David. So we need to have those discussions and I think about that and look at how we best help during that procedures. Otherwise, we do have people with tracheostomies who didn't want them. This was a man who went into hospital for a knee operation and landed up with a tracheostomy. He had been saying he was breathless for 9 months, had chest x-rays, but no one had actually examined him. And it was only after he had his tracheostomy they noticed that his hands looked a little bit funny. we better get a neurologist in. But he made a very clear decision that he did not want to have further investigation, further heroics if his tracheostomy caused problems, and decided that he made an advanced decision not to go into hospital, not to have his tracheostomy replaced, and he died at home. With the most important bits, his glass of beer. He insisted I came back enough room to get that photo in. We've talked about multidisciplinary care, but it's multi-agency, and how do we work out that we don't overwhelm people? I've known patients at home who have said, well, I had the man in the suit, that was me, the lady in blue, the physio, the lady in green, the OT, someone with a bag of food, someone with I don't know what's going on. I've run out of biscuits. I've run out of tea, because they've all had a cup of tea with me, but I don't know who's in charge and what's going on. How do we coordinate that care so that the person feels some control? And I think there are shown to be the advantages of multidisciplinary team, but there are also big issues. I think the more people we have in a team, we have more views, we have interaction with other teams, with respiratory teams, gastroenterology, neuropsychiatry. They work in different ways, but we always sort of assume that everyone else is like us. But it may not be so. And we have to be really aware of how we interact with other teams. And I know research has been suggested, and it never happened, unfortunately, where someone was going to do an ethnographic study of a multidisciplinary team, actually sit in the team and observe it, and see how it worked and who did what. And I think, as Chris said, we need to look at what is the special thing. And it may be that we need, a lot of it is actually you have the confidence within a multidisciplinary team that when someone comes back and says, I'm worried about that person, you all know and work on it. And then end-of-life care. And I hope what's come over is that although I was a palliative care doctor, I didn't always just have the scythe over my shoulder and was only there for the last few days or weeks of life. But palliative care is longer than that. But it includes end of life. Do we anticipate things? Are we communicating that amongst everyone? Are we realising we are getting to end of life? Are we supporting everyone? British doctors have no problem with stress. We work perfectly. We have a very high alcohol rate, drug rate, suicide rate, and divorce rate, but we have no problems with stress. Do we as teams support each other with what we're doing and how we're coping? Do we plan ahead? And in nice guidance, as I said, we wanted to have that discussion when people wanted to talk about it, encourage people to talk, particularly when a new intervention like NIV gastrostomy, talking about what might happen, because if you put it into Google, you will get some very distressing things of what might happen. Are people making their advanced care plans? Are they looking at a proxy? And as the end of life approaches, do we provide that extra support for family and carers to be family and carers rather than professional carers? Can the husband stay as husband and actually have some carers come in to help do practical issues so he can sit with his wife as a husband rather than a full-time nurse and a husband on the side? Do we have more communication aids now? If there aren't, is there a buzzer needed quickly? Do we have the specialist involvement? Have we got that equipment that someone really needs? Is there medication available? And are we looking at bereavement care for families and carers? Because often there is the relief, thank goodness that's all over. I feel very guilty. So we need to be aware of helping in that way. And certainly in the NICE and in our consensus document, we talked about palliative care should be considered early. And there is evidence now that's helpful. The multidisciplinary team papers, I think, show the palliative care approach and generalist palliative care being provided. But there are studies actually in MND and other neurological diseases. This was a study in Turin that I supervised, where it was there were a group of patients. Some had intervention straight away, some waited for 6 months. But during that time, we could see that a big specialist palliative care team was involved with the early intervention group. And over the first 16 weeks, there was improvement in quality of life. Symptoms eased, particularly pain, breathing, bowel symptoms, sleep disturbance. And there were 2 deaths out of 26 in the intervention group and 2 deaths out of 26 in the control group. So it wasn't that we'd killed them all off. So we have to have more evidence of how we provide that care and how effective care can be. Because I think I've been arguing for many years that the Peter Bede model is very helpful. When I started, I used to have the letter from a very esteemed neurologist in our area who'd write, "I'm afraid I've had to refer this patient to you now, David, with MND." Wasn't the best of systems, you know. I was the last stage. As we went on, we had more and more working together. But I think, as Peter said, there is a variable involvement. For some patients, it may be at diagnosis. What on earth is this disease? I am terrified. I don't know what it's under. Or I know only too well about this disease because I've had 2 uncles die of FTT. My mother's died of MND, and I'm really terrified. It may be with gastrostomy, with non-invasive ventilation, with pain, with other symptoms, and then as death approaches. So a variable input, with perhaps the multidisciplinary team providing continuing care and specialist palliative care coming in and out. So where are the areas that research? I think the role of palliative care, the effectiveness and how that MNDT has that effect, I think we have to look at more. There are many symptoms where we need to have more evidence. We need to look about interventions. As has been said, something like gastrostomy that's been going on for so many years, we don't actually understand if it's effective, helpful, good, bad, whatever. How do we look at withdrawal? How do we discuss the end-of-life issues? How do we look at the education and support of patients and families and professionals so that the multidisciplinary teams we'll build up can maintain and build on? So coming back, we need to look at symptoms, we need to look at the psychosocial care, we need to look at that wider support, and we need to provide that coordinated care. Thank you. While Amar's coming up, could I ask, I haven't told him, a little favour? To get my fare to come, I had to promise at the university I'd do a focus group. I haven't been able to do one in Perth. If half a dozen people were able to stay for 15 minutes afterwards, my life would be much easier. I won't have to make so many excuses. Thank you.
Okay, I've already introduced Dr. Al-Chalabi, so without further ado, I'd like to welcome Amar to give her the keynote address. Thanks.
Thank you very much, and thank you to everybody for inviting me. It's been a very interesting day, and thank you all for staying for so long, because I know it's the end of a long day. I've been tasked with talking about motor neuron disease. Where do we go from here? My disclosures are I've got consultancies for various pharma companies. All the money goes into a research support account at King's College London, which I use to fund some of my staff coming to international conferences. So I thought the best way to start would be by talking about how we got here. So 40 years ago, Jimmy Carter was president of the USA. Village People were in the charts. An Atari games console, that's what gaming looked like. Alien, the first movie, was in the movies. A mobile phone looked like a brick, and a computer looked like that. And the state of motor neurone disease understanding was similarly outdated. So we thought there was just one condition, motor neurone disease, whereas as you've heard today, and I'll show you a little bit as well, we actually think there's probably lots of subtypes. It was known to be familial in 5% of cases. We now know that's probably not true either. There was no medication available, not even Riluzole, and most people were just told, you have motor neurone disease, goodbye. There was no way to measure involvement, no way to measure function, and no way to measure clinical stage, and there was no knowledge of any effects on thinking or behaviour for most people. Actually, it was known at that stage because the first understanding was actually in the original studies from the 1800s, and also there was a formal study in 1954 showing a relationship between thinking and motor neurone disease in some people. And also at that time, there was no way to treat symptoms related to breathing or swallowing. So all of that is no longer true. And now I'm going to, rather than talk about the present, fast forward to the future, where the President of the USA, Millie Bobby Brown, for anyone who watches Stranger Things, Ed Sheeran's still touring. He's been aged with the aging app. A games console will be much more futuristic than that was the most futuristic one I could find. The Fast and Furious number 66 in the franchise. Mobile phones and computers looking a bit more futuristic. And hopefully, we'll understand all the different subtypes of motor neurone disease. We'll understand the genetic architecture of it completely. And we'll hopefully have multiple ways to treat it. And I say multiple because if there's lots of subtypes, we need different treatments for each one. Hopefully, we'll have excellent outcome measures so that we can assess whether our treatments are working or not. And we'll have understanding and treatment for extramotor symptoms. So that's symptoms outside the motor system, including not only cognition, but things like becoming very hot or night sweats or things like that, swollen legs, constipation, all the different things that are not strictly within the motor system. And we'll have multiple ways to treat symptoms if we need to, related to breathing or swallowing if it's not a curable form. So other people have shown variations on this slide. This is my particular take. So this is our clinic. Rather than comparing our clinic with general clinics, we compared our clinic with itself. So just when our multidisciplinary team had just started, compared with when the multidisciplinary team is very well established and much, much larger. So over about a 13-year period, we were able to assess that. And taking into account things like non-invasive ventilation use, gastrostomy, Riluzole, there's still a doubling in the number of people living more than 8 years. So specialist care does improve outcomes. So what do we understand about motor neurone disease causes? We know there's two obvious causes for motor neurone disease. Family history, which is present in between 5% and 30% of people, depending on how you define it. And Orla Hardiman has done a lot of work on exactly what we mean by a positive family history. And that tells us about genetics. It tells us there must be a genetic component, at least in the people with a family history. They're very likely to have a genetic component. And the risk increases with age, which tells us that whatever the mechanism is, it must be something to do with aging in some way. We can try and understand how much genes contribute by looking at twins. Identical twins share all of their DNA, whereas non-identical twins share half of their DNA. But both of the groups of twins share most of their environment. And so if something happens simultaneously in identical twins more frequently than it does in non-identical twins, that tells us that it's more likely to be genetic. And these are the actual counts we had. And that, if you do the sums, it shows that about 60% of the variation in whether people get motor neurone disease or not comes from genetic variation that they carry. Now, if 60% of the genetic variation comes from genes, but most people don't have an inherited form, how is that possible? And the answer is that most of the genetic variations that we carry only contribute a small amount to risk. They might only increase your risk 2% or 3% or something like that. But if you have enough of them, then they'll contribute so much to your risk that they'll bring you very close to the threshold of developing disease. So you can carry a lot of risk burden without it being inherited in your family. So just because something's genetic doesn't mean it's inherited. So this is just a genome-wide association study. So this is where we take, in this case, about 40,000 people's DNA, and we've tested at around 17 million different positions in the genome. We've asked, does that genetic variation occur more frequently in cases or in controls? And then the result is plotted. So every dot represents a test. And the higher the dot is, the more difference there was between cases and controls. So you can see wherever it's red, that's where we think it's significant. So you can see there's several genes where a variation increases your risk by a few percent. This graph you've also seen multiple times today. It's actually very out of date. It's only 2 years old. But one of the things you can see on this graph is that gene discovery is doubling every 4 years. So really the rate of discovery is accelerating hugely, and the reason for that is increased collaboration. The different colors for the labels on this diagram also tell us something about the disease. So the green labels are related to the system in the body that removes damaged proteins. So it's like the rubbish collection system in the cells. The red labels are for a system called RNA processing, which takes DNA information and is a bit like photocopying the recipe book, the page you're interested in. It's an important step in translating your genetic code into the proteins that make you. And then the blue is the cytoskeleton. So those are proteins that make the nerve cell able to stay long and strain-shaped. So those three things, the rubbish collection system, the cell skeleton, and the RNA processing system, seem to be important for motor cells. Some motor neuron disease genes don't just increase your risk of motor neuron disease. They're also increasing your risk of other conditions. So, for example, frontotemporal dementia, we've already heard today about various genes that can increase your risk of that, including the ones listed there. Ataxia is a condition where you can lose coordination. So one of the gene variants that increases your risk of motor neuron disease also increases your risk of ataxia. Some have been found in Parkinson's disease. So C9orf72, which affects in the UK 8% of people, regardless of family history, if you have that particular gene variation, that also increases your risk of Parkinson's disease. And again, work done by Orla Hardimann's group shows that there's a 14% overlap between the genetic risk factors for motor neuron disease and the genetic risk factors for schizophrenia. So we know that one cause of motor neuron disease is your genetic makeup. But why are there so many subtypes? If you look at something like Huntington's disease, you've just got one gene and that causes the disease. Why do we have so many, and why are we discovering more all the time? And why is there this overlap with other conditions? So I'm going to leave you to think about that. If we plot a risk graph with age, so this is your risk as you get older and older, what's your chance of developing motor neuron disease? And what you can see is that the older you get, the greater your risk is. So this is, again, taken from Orla. You should have given this talk, Orla. This is from Orla's population register. And what you can see is that by the time you've lived your life, you've got about a 1 in 300 risk of developing motor neuron disease. That's much more frequent than you might think. And the reason why it appears to be a rare disease is because this is the same frequency as multiple sclerosis, same lifetime risk. The reason why it appears rare is because multiple sclerosis doesn't affect your life expectancy, but motor neuron disease does. And so even though there's a high lifetime risk, people aren't around for it to appear common. But this is important to communicate to pharma companies, because then they'll realize they already know that multiple sclerosis is a lucrative thing for them to invest in. They'll start investing in motor neuron disease. The other thing you can see is that the risk to men is always higher than the risk to women. We don't know why that is. So, why is age important? Again, I'll leave you to think about that. And environmental risk factors. We've heard today quite a bit about environmental risk factors. And anybody who attended the debate in Perth will know that I had to take a very extreme view and say there were no environmental risk factors at all for motor neuron disease. I don't think that's true. But the difficulty we've had is these are all possible associations: military service, where you live, smoking, exercise or sport, infection, electric shock, physical trauma. It's very difficult to replicate these studies. The closest we've got to doing really high-quality studies have been from the Euromotor Consortium, which was led by Ned van den Berg in Utrecht. And even that study is difficult to replicate, because to do that we had to collaborate across the whole of Europe And it would require another group to collaborate on that kind of scale and do very, very detailed studies over years. So we can't be sure which environmental risk factors really matter yet. As an example, this is over a 10-year period. Each dot represents every case of motor neuron disease seen at the King's College London clinic. The black dotted line on the left there is just the western border. All the rest is bounded by sea or river. And you might be able to see your own clusters. So I can see a cluster around London, and there's a bit more around the coast, it looks like to me. So you might think, well, this clustering around the coast, there must be something to do with the sea. But it isn't. People with motor neuron disease, people who in the UK who retire tend to retire by the coast because it's warmer and it's nicer. And I've already shown you that the risk increases with age, so you're going to have more cases around the coast just because it's an older population. And the hotspot in London isn't a hotspot, it's just there's more people live in London, so you'll have more cases. And when you correct for these types of factors, you can show there are some areas where your risk might be slightly increased or slightly decreased, but there's no really striking clustering that we ever see. What about viruses? So I've chosen viruses because we've already talked about the other risk factors, and I knew no one would talk about viruses. Poliovirus causes a motor neuron disease. You get polio, and then if you're susceptible to that virus, if you exercise that limb, it'll become paralyzed, and it's a fixed deficit. So do other viruses cause motor neuron disease? Well, we looked at this in about 1994, and we collected blood from people with motor neuron disease and from controls, and we looked for a retrovirus signature. So a retrovirus is a virus that doesn't behave like normal viruses. Normal viruses are made of DNA, they go into your cell and they reprogram it and they make more virus. A retrovirus starts as RNA, gets converted backwards into DNA and then starts the process. So they're slightly strange viruses. And we found that 59% of people with motor neuron disease had a signature of retroviruses in their blood, but only 5% of controls did. And we then did another study where we compared relatives and spouses. And we found that if you're a relative, about 59% of relatives also had this signature despite not having motor neuron disease, but the spouses had the same rate as the general population. So that's actually not the pattern of an infective disease, it's the pattern of an inherited condition. So you might think, how can a virus be inherited? It seems crazy. But actually, we all carry lots and lots of inherited viruses. They're called human endogenous retroviruses. They're ancient viruses. They're all retroviruses. They're embedded in our DNA. And they're in the same group as HIV, but they're not infective. They're just carried in our genome with us. They're just carried down through evolution in our DNA. And they take up 8% of your DNA. Now, to put that in perspective, 1% of your DNA codes for you. So 8 times more of your DNA is coding for these ancient viruses than it's coding to make you. And they've become so much part of us that they're even essential to make your placenta. So human placentas require these retroviruses in our DNA. One of these, called HERV-K, has recently been found by Avindra Nath at NIH to possibly be the culprit. But that would be a genetic cause, not an environmental cause. So despite us looking for viruses, we can only find a genetic link to viruses, not an environmental link. So it's difficult to find environmental causes. Why is that? So I'll leave you again to think about that. So is motor neuron disease one condition, or is it many conditions? So who thinks it's one condition? Nobody. You think it might be. It's an umbrella term. Yeah, it is an umbrella term. Yeah. Yes, I agree with you. So I think it depends on why you're classifying it. There's lots of ways you can chop up motor neuron disease, and it really depends on why you're doing it. And sometimes it's convenient to think of it as one thing, and other times it's more convenient to think of it as lots of different things. Yes, a spectrum. We need to measure the right things. So what I want you to do here, I want to test your powers of observation. So I want you to imagine you're in clinic and that the stars are the symptoms. Okay? I want you to observe the sky. You'll notice that the sky changes as time goes on, just like motor neuron disease symptoms change as time goes on. You'll notice that sometimes the symptoms are obscured, sometimes they're not. Sometimes there's very prominent symptoms, other times there aren't. So I just want you to observe that. Now, when we see people with motor neuron disease in a clinic, we see them as a snapshot in time. But the actual process is like this. It's evolving over time. It's a continuous thing. But we have to come to all of our conclusions based on one snapshot at the beginning, usually. So, did you observe that well? I'm going to test you now. So there's a single shot, so that's your clinic visit. Was that at the beginning of the disease, the middle of the disease, or the end? So who thinks that was at the beginning? So a few of you, okay. Who thinks that was in the middle? A few more, and who thinks it was at the end? Presumably everyone else, yeah? So you're right if you thought it was at the end. It is actually at the end. So now your next task, so you've worked out roughly where you are in the disease process. I want you to tell me what you can see on there. Because now you've got to observe the patient. We've got to measure the right things. And we have to know what we're looking for to be able to come to the correct diagnosis. So what can you see on this picture?
I saw a shooting star.
A shooting star, yeah. There's a shooting star there. Very good. Southern Cross, okay. It wouldn't because it's taken from my back garden, which is in England. So it's not the Southern Cross. but that's Cassiopeia, so I'll give you that as a constellation of stars. Yep. Anything else? A planet, did you say? A building, sorry. So there, yep, that's my neighbour's house. Anything else? The moon, very good, yep, the moon.
Jupiter.
I'm sorry? Could be, you mean there? Could be. So let's have a look. So I'm going to focus in on that you've just pointed out, David. So that bright star there, if we zoom in on it, does it look any different from any of the other stars? It looks a bit brighter. Okay, let's go in a bit deeper. Can you see anything now, any detail? I'll go much deeper now. Okay, it was actually Jupiter with its moons. Okay, so it just looked like a star when we were looking at the first picture. And unless we knew it was a planet, we wouldn't have looked for it. And that's why frontotemporal dementia, as a feature of some people with motor neuron disease, wasn't recognized for years. Really, I would say until about the last 10 years, 12 years, it hasn't really been something that anyone's looked for. And even now, as you heard from the Q&A session, most people don't assess it. But it is present in many of our patients, not in everybody, but in enough that we should be looking for it. And there may well be other things that we should be looking for that we don't know that they're there, just like we couldn't recognize that as a planet. There are probably lots of other things that we're not recognizing. And part of what we're doing in a collaboration called Brain Mend, involving Chris and Orla and other people, is looking for methods to try and find out what those other things we should be looking for are in motor neuron disease. So knowing what to look for is important because if you can observe things, then you can classify correctly. And we see a snapshot view of a continuous process. So in this shot, I've kept the ground still and I've let the sky move. So if I told you that was an hour's long of the night, then you'd know roughly how fast the stars were moving. If I told you that was 5 minutes, then you'd know that the stars are moving much more quickly. And if I told you that was 10 years, then you'd know they're moving very, very slowly. So when you see a rate of progression information, you can, if you know how long it's been over, then you can tell information from it, but you lose the detail of the symptoms. But you can understand the rate of progression. If I look at the same thing, but this time I've kept the sky still and I've let the ground move, so now you can see the symptoms, and if I tell you that's over an hour's period, then you can see, well, that's roughly what the sky looked like then. So that's what we call clinical staging. So that's where you divide the disease up. Instead of saying it's 3 years since the disease started or 6 months or whatever, you say this is early disease, this is middle disease, this is late disease. And you can divide the time up into roughly equal blocks by doing this kind of process, but obviously with symptoms. And there are various staging systems. The King system and the MITOS system are the ones most widely used at the moment. But really, ideally, we should be able to just do a blood test or something like that, some kind of biomarker that Martin might have developed that would tell us where we are in the disease progress. That would be a much better way. That's really what we want for where we're going. So things we measure have changed from the 1870s to now. So at the beginning, we were just measuring clinical features. Then we started to measure biochemical things and also things that they didn't think to measure at the beginning, like breathing, and now we're getting into spinal fluid. But what we really want is these robust biomarkers, both for diagnosis, because at the moment, when someone comes to us and says, do I have motor neuron disease, there's no test for it. We have to test for everything else it might be, and then say, well, it isn't those things, so we think you've got motor neuron disease. That's not very satisfactory. We need something for stage, as I said. And also, it'd be good to have a marker that measures disease progression. And that way, if you've got an effective treatment, you'd hopefully see that marker change back towards an earlier disease state. So why does the type of motor neuron disease matter? I'm not doing a magic trick, I'm just getting some water. It matters because of precision medicine. So if you have a cold and you need antibiotics, your doctor doesn't just randomly give you some antibiotics. Well, they might, but in the UK they don't, I hope. So they give you antibiotics based on the infection you've got. So if you're in hospital, they'll take your blood, they'll culture it, find out what the bacteria were, and then they'll give you the right antibiotic. The antibiotic is trained to the infection you've got. So that's a targeted treatment because we've got a deep understanding of the causes. It's the same with a blood transfusion. If you need blood, you're not just randomly given blood. Your blood type is measured, and then you're given the blood that's compatible with your immune system. So really, we should be doing clinical trials in motor neuron disease in the same way. We should be targeting our clinical trials at specific patient groups correctly. So I'm going to give you a trial here. So this is the muffin taste test trial. So they've been baked by lots of different bakers. Do you think they all taste the same? No? Okay, so we'll go a bit closer. So half of them are chihuahuas, as you may have seen. Okay, so you wouldn't want to eat the chihuahuas. So it is important to classify patients correctly in the same way it's important to do this. So if you were doing a taste test trial, you'd want your muffins and your dogs kept separate. And we can stratify our clinical trials already to some extent. So this is work done by Michael Van Ness, Adriano Keogh, and our group, where we looked at lithium trial data. So lithium has been looked at as a possible treatment for motor neuron disease in 6 different clinical trials a few years ago across the world. And all of those studies showed there was no benefit at all of lithium in motor neuron disease. And Michael Van Ness had this idea that one possible reason for that might be that some people who had a genetic variation that made their disease more rapid, they might have been in the treatment arm by accident, and therefore they were being treated, but they had a more rapid disease, so the two things cancelled out, and therefore it made it look like it wasn't working. So we went back and looked at the genetics in the 3 different groups that we had access for. So 3 of the studies had genetic data and clinical data where we could do this. And what we saw was quite interesting. So this group here, this group here has a genetic variation in a gene called UNC13A. And that genetic variation makes you have a worse disease trajectory, as you can see. So their disease is worse than everybody else's. They've got a faster disease progression. But these are the people who are on placebo. The people on actual treatment, their disease trajectory corrects to be the same as everybody else's. So it's not a cure, but it changes them from having a terrible disease trajectory to just having a normal disease trajectory. So that's something that's come out of stratification by genetics. Now, 10% or 20% in some populations have this genetic variant. So it's only increasing your risk of motor neuron disease itself by about 2%. But if you have motor neuron disease, it does this to your disease trajectory. We've heard about gene therapy trials, so I'm not really going to talk about those in great detail, but just to say that they're looking very promising. So we should be able to target types of motor neuron disease, but what else do we need to learn? So here are some mysteries. I've given you some of the mysteries as we've gone along. I hope you've been thinking about them and you know your answers. So it increases in risk with age. There doesn't seem to be a single cause. Environmental causes are difficult to find. And one gene variant seems to be able to cause more than motor neuron disease. Some of them cause motor neuron disease, others don't. And not all gene carriers develop motor neuron disease. I haven't told you that, but you can carry a disease gene and never get the disease. That's called reduced gene penetrance. So about 30% of people with the C9orf72 mutation will develop motor neuron disease, and the other 70% won't. So why is that? And it also seems to start in one region. So it might start with a swallowing problem or a hand problem or a foot drop or something like that. And then it seems to spread from that region. And also, why is it specific to motor neurons? Why isn't it affecting your sensory neurons or other types of nerve cell? So these are all mysteries that are difficult to explain. We can look at the cancer model, where a lot of those things are also true. So in cancer, there's what's called a multi-step process. So this is an example of it. These aren't real. These are just my imaginings, but some people are born with a genetic background that predisposes them to cancer, so something like the BRCA1 gene that you may have heard of. And then if you smoke, for example, it gives you some additional mutations. Perhaps you get a virus infection and then a bacterial infection that activate your immune system a particular way. Maybe you drink too much coffee and that affects those cells, and then you get cancer. Okay? So I'm not saying this is true, this is just an example. But this multi-step process might be the kind of thing that's happening in motor neuron disease. And we can actually test that. And the reason we can test that is because it's very easy to spot multi-step diseases. You can just do it with some simple maths. If anyone's interested in the maths, I can show you it afterwards. But basically, we can plot a log of the incidence, so that's the number of people affected per unit population. You can plot the log of that against the log of the age at which you're measuring how frequent it is. And if you get a straight line in that graph, that means it's a multi-step process. If it's not a straight line, it's not a multi-step process. Okay, so all we're looking for is a straight line when we do these graphs. And the slope of the line, that's how steep it is, tells us how many steps there are. So we applied this to our Southeast ALS register in the UK, and it looks fairly straight. You get that's the graph. And this number at the top here, the R-squared number, that's a measure of how close to a straight line the fit is. The closer it is to 1, the better. And 0.95 is actually very, very close. That counts as a nice straight line in a research study. So then we went to our colleagues in the Netherlands, Leonard van den Berg. We got a R-squared of 0.99. In Adriano Chio's register in Italy, it was 0.95. In Orla Hardiman's register in Ireland, it was 0.99. And in Rob Swingler's register in Scotland, it was 0.97. And then when we combined them all, it was 0.99. And what that tells you is all of them had the same slope, because if they'd all had different slopes, it wouldn't have been a straight line at the end when we combined everything. So actually, since then, our Australian colleagues, Steve Vucic and Matthew Kiernan, have done it as well and shown exactly the same thing with the same slope. So it's now been shown in multiple populations that it looks like a multi-step process. And if you do the maths, it comes out that the slope is 5, which the slope is always 1 less than the number of steps. So that tells you that motor neuron disease is a 6-step process. Now, interestingly, Adriano Chio then took this further and looked at the genetic subtypes within his register and was able to show that for some of the genes, they actually account for many of those steps. So if you carry the C9orf72 gene mutation, then 3 of your steps are accounted for, and you've only got 3 more to get. And if you carry an SOD1 mutation, you've got 4 steps accounted for. You only need 2 more steps to get the disease. And that's why having a gene variant can look familial. If it's one of these big effect genes, it uses up so many of those steps, there's not many more to get, and so you're very likely to get disease. So actually, that multi-step process explains many of those mysteries. The increasing risk with age is because you need to live long enough to accumulate all the different steps, to have been exposed to all the things that will cause the steps. The fact there's no single cause is because lots of things can cause the steps, just like a mutation can be caused by smoking, by X-rays, by flying too much, by living in a granite area. All of those kinds of things can increase your mutation rate. Environmental causes are difficult to find for the same kind of reason, because lots of different things can cause what you're looking for. And also, there's 6 steps. So if environment accounts for 5 or 6 of those steps, then you've got lots of different things that can cause it in each person, and they might not each be the same thing. You're looking in a huge search space for lots and lots of things. One gene variant can cause different diseases, because if you go 1, 2, 3, 4, 5, 6, you get motor neuron disease. If you get 1, 2, 3, 4, 5, 7, you get frontotemporal dementia. So if you've got slightly different steps, even though lots of them are in common, so the gene variant might be in common, the other steps might be slightly different and might result in different diseases. The reason not all gene carriers develop the disease is because unless you get all of the steps, you're not going to get the disease. And the gene carriers account for 2, 3, or 4 of the steps. You still need the other steps to go through. It starts in one region because one set of nerve cells has to be the first one to have gone through all of the steps. And it's specific to motor neurons, probably because at least one of those steps can only happen in a motor neuron. So you might think that's a slightly crazy idea, but actually there's a naturally occurring example of this. So this is the multi-step mouse model of motor neuron disease. This is a natural mouse. It's not a lab mouse. It's a mouse found in the wild. And these mice, some of them have multiple copies of the equivalent of that retrovirus I showed you that humans have. So mice also have these, because all mammals do. And some mice have lots of copies, and other mice have hardly any copies. And some mice have a gene variation that switches on that virus, and others don't. And if the mouse that has multiple copies and the switch on happens to get infected by another virus called LDV virus, then it will get motor neuron disease. So that's an example of a multi-step process with genes and environment involved. So you've got a genetic predisposition, you've got to have this other viral infection, and then the mouse gets motor neuron disease, and it's a multi-step process. So can we put all of that together? I think we probably can. It looks like I've done all my work with you, Orla. This is another thing I wrote with Orla Hardiman. She's not my only collaborator, I promise. Where you're born with a genetic load, you get cell damage with time, and then you have environmental exposures. So that's GTE. And the idea is that unless you have enough of a burden to reach this threshold, you won't get disease. But if you do have enough of a burden, then you'll get onset, and then you have a self-perpetuating process that leads to MND. So the 6 steps would go along the bottom there. And you can imagine that some people have lots of small genetic risk factors that are all contributing. Other people might have one large genetic risk factor if they've got familial motor neuron disease. And one of the things that you can observe from this is if you have got the genetic risk factor that's taking up a lot of space, then you should probably look for environmental risk factors in that group, because you've only got 1 or 2 different steps to look for. It's a much smaller search space than trying to find it in people with sporadic motor neuron disease, where there's lots of possible causes for each of the steps. So where do we go from here? We've had massive progress over the last 40 years. We've got much greater knowledge, much greater ability to measure things. We've got better approaches to treatment development, and I hope over the next 40 years we'll have much greater advances. Precision medicine is probably the way forward for at least some types of motor neuron disease. Each person is different, and then you could target therapy, and you could do better ways of doing trials, which I haven't really talked about today, but is also important. And we need to understand how to distinguish the different types of motor neuron disease, where we design a treatment specific to each person, and for that we'd probably need biomarkers for all the different aspects of the disease. So those are my funders. I'd like to thank all the patients who've contributed, because without them we can't do any of the work. And this is my research team who've done all the work that you've seen today. Thank you.
Thank you, Amar, for such an entertaining, fascinating, thought-provoking keynote address. One of the things I love about your presentations is you make it easy for non-researchers like myself to understand and make us feel very smart afterwards. So thank you very much. Just a little token. Thank you.
Thank you. It's very kind.
Thank you. And don't test me on it, though. I see a few people have had to go. Obviously, we are running over time, so I'll just quickly hand over to Dr. Emma Scotter for our closing address. Thanks.
We've all learned a lot today. It's been just an absolutely wonderful chance to bring all of our New Zealand stakeholders together in one room, and also to have these absolutely inspiring international speakers come. And I've learned many things, and one of them is to always include chihuahuas in my talks. So we have a real feeling of momentum now, I think, around motor neuron disease research in New Zealand. And, you know, I had a long list of things that we needed to think about, you know, developing infrastructure and capacity around people, leveraging our expertise, all these things that we need to do. But I think the expertise is actually right here in this room. And, you know, hearing Orla talk about what's been done on this small island with very little money and few people, I think the people that are here need to really to step up and bring their enthusiasm and their respective knowledge to this terrible disease. And I think we do have the capacity in this room to continue on the momentum we've already established. So I'll give a bit of a summary as to what we've learned today, and then I'll just skip to thanking all of the parties who have really been involved. So I think we've seen that we really have some vital infrastructure already present from our patient registry, and we know from our international colleagues that there are prognostic and possibly predictive biomarkers of disease. Finding that TDP43 is a common pathway in almost all cases of MND, and its discovery as a genetic cause of the disease has really flipped the field on its head. And since that time, the massive genetic cohort studies that people like Amar are running have revealed that there are many more genes, and that there are genetic therapies that may start to really tackle these gene mutations. So although it seems likely that genetic and environmental risk of MND accumulate in a stepwise fashion, as Amar told us, I think that by choosing the right target, genetic therapies may actually be a tractable therapy and a tractable strategy for everyone with MND. And very encouragingly, our second session really showed us that living with MND is being made easier. People like Sarah are really just bringing these out-of-the-box approaches to making life more comfortable for people living with MND in the absence of a cure just now. So I do think we're heading in the right direction, and our recent initiatives and today really show that that is true. So on that note, I'd really like to thank the people who have spearheaded this. I had really a small role to play, but I'd like to really thank Lydia and Claire for their huge role in this, and I have a couple of gifts. I think, Claire, that Carl has already given you a gift. I hope he has. But I'll also invite Carl to come up for a gift, and Nicole for being our photographer for the day. And I'd also really like to acknowledge the MND team. Many of you are here, and they've been plugging away in the background, the beautiful programs that we have, the beautiful slides that they've created. I think the choice of room really has brought a kudos and a gravitas to this event that has really made it a wonderful day. Just the very final closing words, I would like to say, to reiterate what I've said earlier, we really need to push, all of us in this room. We are the stakeholders, and there's no point looking outside to who might do this, because it's us in this room. So we need to push for the infrastructure for MND research in New Zealand. We need to push for funding, the expertise and access to these potential therapies that are being developed elsewhere. All of these things exist in this room. So don't look outside this room, look to yourself to do something. We do need to do more, faster and better, but today gives me huge confidence that we will. So it's my great pleasure to close this meeting and say thank you very much to everyone who's attended.